Sir, namaste. Good evening, sir.
Okay, ma'am. Thank you.
So we are
Vidya ma'am.
live now. Hello.
Good evening. Yes. We are live
So
now?
we are live now.
Yes. Good evening, respected faculties. I welcome you one and all to this Well-Women Webinar Series 2, Episode 13, in association with, this is Himatnagar Obstetric and Gynecological Society, along with, in association with the Tamil Nadu Societies. So we have our program director and the convener, Dr. Deepika Logane from Delhi. Next. And we have a program director. Yeah, Dr. Deepika is with us now. She's a senior consultant in OG at Delhi. Next slide, please.
Hello. Hello.
Yeah.
சரி,
So
அப்போ நீங்க
we'll start
ப்ரெசன்ஸ்
with
என்ன
the
சொல்லிடுறீங்களா? நான் வெபினார்ல இருக்கேன்.
and we have the program director, Dr. Sarfaraz Kasi, who's the chairperson of Safe Motherhood Committee of SOGOG and also the president of the Himatnagar Obstetric and Gynecological Society. So, Sleevy, please. Dr. Sarfaraz Kazi is an onco-gynecologist, and he is a consultant gynecologist, endoscopy, and infertility specialist with more than 20 years experience, and he's a member of Society of Fetal Medicine, organizing vice chair of SOGOG 2023, president of Himatnagar OG Society, and chairperson of Safe Motherhood Society of SOGOG, and he's also the state coordinator of Sexual Health Committee and STI Committee of FOXY, and North Zone coordinator of Gujarat chapter of ISAR. Over to you, sir, to welcome the dignitaries.
Thank you very much. First of all, thank you very much for all the esteemed faculties and dignitaries to join this Well Women webinar series 2, and this is our 13th episode. Welcome, Sampath Kumari ma'am. We have included almost 16 societies of the Tamil Nadu with respected our all guest of honors and special guests. I am welcoming you on behalf of our team. Dr. Deepika is the convener for this webinar. Dr. Radhika is coordinator, and Dr. Madhumita, who has done a hard work to gather all the panelists and all the speakers and chairpersons for this webinar. Dr. Radhika is right now Secretary of Uttarakhand OBGYN Society, and she is private practitioner at Dehradun and
That's it.
member of this committee, Foxy. Welcome, Radhika.
Thank you, sir.
Next,
Thank you for the opportunity.
Dr. Aruna Karthik. Madhumita Arun Karthik is a national coordinator of midlife management committee. She is doing very hard work all over the India. She is doing this Manu Ben Ki Tapri. The new concepts she has started and very interesting webinars they are doing under the name of Midlife Management Committee. Right now, she is the secretary of Salem chapter of Ishar and South Zone and Tamil Nadu State Coordinator of Foxy Presidential Activities for 2026. Welcome, Madhumita. So this is our team, and on behalf of our team, we are welcoming our all guests of honors, all the dignitaries and respectful personalities of the Tamil Nadu Society and the Foxy, and who all are involved not only in the Foxy but SAFOG and AOFOG. These are our guests of honors. First of all, I would like to introduce Dr. Jayam Kannan, ma'am, the most respectful personality. Please, CV of Jayam Kannan, ma'am. Jayam Kannan ma'am was past Foxy President of 2018, and she is Emeritus Professor of Tamil Nadu MGR Medical University, President of India Medal. She won for outstanding performance in MBBS. She has started with the medals from the MBBS, and still the medals and awards and editing the papers and all things are continuing till date, and she is very hardworking still at this stage. A.L. Mulligar Award she got at the when doing the MD, and Best Book in Medicine Award 2 times from Government of Tamil Nadu, and Lifetime Achievement Award 6 times. She is Maneta Lead Assessor with exceptional commitment since 2016, and Distinguished Service Medal 2018, first Indian to receive from the RCOG in 2018. Ma'am, now stage is yours. Please give your blessings to this webinar.
Thank you very much, Sarfaz. I think I met you at
In
South Africa
South,
trip.
yeah,
We
yes, South Africa.
lovely had a very good time, The
Yes,
way we went around the forest is
yeah.
Yeah, coming back to it, I know Kazi is very, very hardworking, and you have started yourself enthusing into Foxy a couple of years ago. And this core connect which you are doing in Tamil Nadu with all the 16 societies, probably a couple of societies are yet to join. Yes, of course, the subject you have taken is right from urine test to positive, where we land. Are we safe in the first few months of our pregnancy? Which is always a question in 20% of the couples who have shown urine test positive. You have taken Charmila to speak aptly on early pregnancy, placental modulations with the hormones we supply. And once we pass through the early pregnancy loss, you are there to stitch the cervix in time to prevent the next 15% of, next 5% of pregnancy losses which you can undergo. Of course, with all these things going on, repeatedly, recurrently, depending on the various definitions by all over the world, but still in the minds of the patient, one pregnancy loss means in the next pregnancy she is always worried. She is not bothered whether ASRM says 3 and X-ray says RCOG and X-ray says 2, or this says 2, that says 3, WHO says 2, all these things is not worried. So one pregnancy loss means patient thinks that she is going to be losing the second baby, and that is going to be a good panel moderated by Rekha Rajesh Kumar. I think I'm very sure that for this year, this is the first program which is connecting the entire Tamil Nadu. All the best for you, Sarfaz Kasi, and all the best to Dr. Sampath Kumari, who is leading the Tamil Nadu forward this year, to be followed by again another Tamil Nadu person, Dr. Charmila, next year. I'm very sure the entire Tamil Nadu will stand behind these two people and do their best to see that a long felt need for a Tamilian to occupy the chair of Foxy. All the best for you, Sarfaz, and to your team, and to my sweet Madmita.
Thank you so much, ma'am. Thank you.
Sir, you're
Sir,
muted.
you're muted, sir. You're muted, sir.
Hello. Now okay.
Yes, sir. Yes, sir.
Oh.
Yes, sir.
It's my proud privilege to welcome the respectful Sampath Kumari ma'am. We everybody knows that the proud figure from the Tamil Nadu in the Foxy. She is right now contesting for the president post, and we are hoping best wishes for her. She serves as a vice president in 2022-2023, and she is the founder secretary of Tamil Nadu Federation of OBGYN Society. She worked also in FIGO Committee on Adolescent and Youth Health, member on Co Committee, AOFOG and SAFO. National Corresponding Editor of the Jogi and Senate Member of Tamil Nadu, Dr. MGR Medical University, Chennai. President, Board of Studies of OBGYN Tamil Nadu, Dr. MGR Medical University, and in 2015 to 2020, Chairperson of Adolescent Health Committee. Her area of interest is adolescent health to improvise all
Thank you,
over
Prakash. Thank
India.
you, thank you.
And
Thank
mainly, lastly, first ICOG distinguished governing council member and many awards and publications under her belt. Ma'am, please, we need your valuable blessings for this webinar.
Thank you, sir, first for including me. Anyway, this webinar is the third webinar series, I think, with Tamil Nadu. And you are doing a wonderful work. And I am proud to be associated with Jayam, Kannan madam, Ramani madam, and Palaniappan, Vidya Prabhakar, and all of them are a special guest and guest of honor, I think. Anyway, all the best for the success of the webinar and all the best for your committee chair when I think you are contesting for Sexual Health Committee. All the best for this. We will have our support with you. And finally, I am contesting for Foxy President. All of you, please support me. And best wishes for the success of this webinar. Thank you, sir, first.
Thank you very much. Thank you very much, ma'am. Your wishes matters a lot for us, not only for the webinar, but all our career. And we all are hoping very best to see you as the president of next Foxy from the Tamil Nadu. Thank you very much, ma'am. Next, CV. Our next guest of honor is Professor Ramani Devi, ma'am, who we all know her very well. She is the great academician. She has many awards and accolades under her name, many publications she has published. She was the president of Tamil Nadu in 2024. I am welcoming you, ma'am, on this board. National VP of Fox in 2020. And not only India, she has given her services to the Bangladesh, also International Advisory Board member of Fertility Society. If we will talk any association, whether it is ICOG, whether it is SAFOG, whether it is Foxy, whether it is Tamil Nadu Federation, she worked each and every place. Worked as a ICOG governing council member, managing director of the Ramakrishna Medical Center, chairperson of Medical Matters Committee.
Dr. Sarfaraz, thank you so much for your kind introduction.
Ma'am, last APJ Abdul Kalam Award you have won in 2016, and we many more awards under your name. The great personality from the Tamil Nadu joining our webinar. This is our pleasure and prestige. Please, ma'am, give your blessings.
Sarfaraz Kasi, for your kind words of introduction. I am very happy to be the guest of honor for this program today. A web series that is on well woman conduct started by you, and the topics really you have chosen today, that is in threatened abortion or early pregnancy loss, and also emergency in Cerclage. Both of them, I think they are very important, because we have to understand one thing. If there is spotting during the first trimester, then the patient is at high risk and she is likely to go in for a continuation of pregnancy, may be hampered in many ways. And hence, this particular patient needs a very careful follow. The second one is emergencies in Cerclage. That is also a very valuable one, because we know that many of the lives of the fetuses have been saved because of emergency. Hence, that is one. And then again, on recurrent loss, I think that is very close to my heart. And we have so many reasons for this RPL, and many more newer things are all entering into this particular topic. And I hope the moderator and the panelists will discuss about them. For example, even a simple abnormal microbiome or dysbiosis can lead to recurrent pregnancy loss, and correction of simple things like the septum, as well as chronic endometritis. All those things will improve the outcome. So I wish Dr. Sarfaraz very successful webinar series, as well as success for your future endeavors. And I'm also happy that my dear friend Dr. Sampat Kumari is here, and I wish she should become the president of Foxy to represent the South Indians after a very long time, and I wish her a very, very excellent future and outcome in near future. Thank you for the opportunity given. Thank you.
Thank you very much, ma'am, for your word of wisdom for this webinar and for our future. Thank you. It's your blessings means a lot for us. Thank you very much, ma'am, for being here as a guest of honor. Our next guest of honor is none other than the most prominent personality of the Tamil Nadu, who is known for spreading happiness all over the Foxy, Dr. N. Palaniappan, sir, who is welcoming you, sir. It's my pleasure on this webinar on behalf of all our team. Sir is right now professor and head of the Department of OBGYN Sri Ramchandra Medical College, Chennai. And recently, he was the Foxy vice president, also worked as a chairperson of the Safe Motherhood Committee in 2017, and also serves as a president of the Chennai Society, OGSSI 2020. Many awards under Sir's name is Kamini Rao Yuva Foxy Orator. His oration is very well known in all over the Foxy. Whenever Sir is going to give the oration, the hall we have seen the full jam packed, and everybody is so much interested to hear the presentation of Dr. Palaniappan sir. He is the master in presenting any topic at the national platform. Sir is Young Gynecological Award of the Asia Oceania Federation of Obstetric Society in 2007. He also authored the many chapters in textbooks and interested in high-risk obstetrics, and joint organizing secretary of AICOG 2015, and also ICOG governing council member in 2019 and 2021. Sir, stage is yours. I think sir is driving. We need your super fast blessing, sir, from the steering. Sir, we cannot hear you. Is there any problem? Madhumita?
Yes, sir, I think no, sir, no problem, no technical problem here, sir. I think.
Okay, so sir is speaking, but I cannot hear.
Is it, sir? I'm not
Yeah.
able to see sir on the screen.
Sir is there.
Sir is on the screen. I think
sir is driving.
muted.
Sir
Okay,
is
maybe.
muted.
So you muted, sir? Palaniappan sir is muted. Sir is here.
Yeah.
Yeah.
Now.
Yes, sir.
Yes, sir.
Yes.
Now we can hear. Sir, please.
Audio is not connected.
I think audio is not connected, no, sir.
Only sir, audio is not connected.
It's unmuted, but audio we're not able to hear, sir.
Yes.
Hear you now?
I think if one of us can call sir and he can say his words on the speaker, I think that will be easy. Kazi sir, if you can call sir and put him
Yes.
on loudspeaker, that will be.
I'm calling.
You're able to hear me now?
Now, okay. Now, yes.
Yes,
Sarfraz,
sir.
you're able to hear me?
Yes, sir. Yes.
Okay. Yeah. Thank you very much, Sarfraz, for having invited me to this wonderful webinar. And I'm able to see a lot of Tamil Nadu friends whom I've not seen for quite some time. Absolutely familiar faces. And thank you very much. I'm able to hear all of you very well. And I had to listen to Dr. Ramani Devi and Sampat Kumari Madam talking to me before me. And thank you very much for this, and extremely happy to be a part of this panel and of speakers. And I'm very grateful to Sharfraz for calling. We met Sharfraz a couple of years back, and I'm sure we had a wonderful time at the Kanyakumari Vice President's Conference where you were there, and then subsequent conferences after that as well. And this webinar has been very well planned with the entire Tamil Nadu gang. And there are enough contestants for Foxy here and for various other organizations. I'm extremely happy that Tamil Nadu is booming with contestants and candidates for various elections. But anyway, not less though in academics. And so to prove that, we have a wonderful speaker here, Charmila, who's going to do a wonderful job on the early pregnancy loss and drug supporting them. Of course, Sharfraz and Dr. Sampath Kumari, my dear friend who's contesting for the President Foxy. I also wish that people here take over the backing from the other people and follow the legacy. And we need Tamil Nadu to be more in the Foxy scene. So wish you all the best, Sarfraz, and wishing this webinar a very wonderful success. And I wish everybody here and happy to be a part of this webinar, and all the very best to all the contestants of for the recent elections, which is going to happen soon. And happy to be a part of this. Thank you very much.
Thank you. Thanks a ton, sir. Thanks a ton. It's always pleasure to see you on the screen, smiling every time. And thank you very much for your wonderful word of blessings. Thank you. Though you are driving, you are so committed that you join on time. Thank you very much, sir. After our guest of honors, now it's time to invite and welcome our two special guests, Dr. Vidya Prabhakar ma'am and Dr. Amala Devi ma'am, who is right now the backbone of TNFOG, because Vidya Prabhakar ma'am is right now the president of Tamil Nadu Federation, and Amala Devi ma'am is, I think, going to be the next president. Well, I am welcoming you, Vidya ma'am, on this platform. It's with all my respect. She is right now the president of Tamil Nadu Federation, past president of OG Society of Salem, completed her study from MAMC
Thank you
in
very
New
much.
Delhi.
Thank you very much, Dr. Sarfraz. I think there is a whole lot of people here on your honors list. And I think thank you very much for inviting me here. And first of all, let me say I was really amazed at the galaxy of stars you've collected for this one webinar. My God, and you've been very hardworking. I know you've been making so many calls and making almost all the stars of Tamil Nadu over here. Maybe probably one or two are missing. Most of them are here today. Maybe they are waiting for the next webinar. And actually, so the topics are also very good. As very rightly said, early pregnancy bleeding and the progesterone support. Actually, if you go to the West, in the UK and US, I hear that not even the doctor will look at you if the patient goes with early pregnancy bleeding. So the sister herself will tell her, okay, so if you are still pregnant at the end of 3 months, I will have a look at you and then get an appointment with the doctor. That's the way it goes over there. But here in India, we are so concerned, and very rightly so, because the patients are definitely very much apprehensive at that point of time. And sometimes I do feel that there might be an overkill, because sometimes a lot of prescriptions are there with so many other, mixture of drugs. I'm sure Dr. Chamla is going to bring out that, what is the right kind of support and what is not required. And of course, recurrent pregnancy loss is a very, the topic very close to my heart. And any number of times you talk about it, there's something or the other, and something new comes up every time. So I hope lots of new things will be uncovered today in that topic as well, and emergency and Cerclage as well. So all are very nice topics and a lot of enlightening today. And I'm very happy that you invited me to be part of this webinar. And I wish you all the very best for your upcoming elections. And I wish Dr. Sampath Kumari ma'am all the very best for her election. We hope to see her as the next president of Foxy. And all the other stellar cast today, I wish a very good evening, and wish you all the very best, whoever is standing in the elections. Thank you very much.
Thank you very much from the bottom of our heart for your blessings and your wonderful words. Thank you, ma'am, for joining our webinar. It's our pleasure to have you on this platform. Thank you, ma'am. Our next special guest is Dr. Amala Devi, the most senior person, I think, from the group, from the Tamil Nadu, and she is now going to be the president of Tamil Nadu Federation of OBGYN Society from next year, from next tenure. Right now, she is the senior most consultant at Annai Perinbam Hospital, Dindigul. She is the founder secretary of the Dindigul Society and past president of Dindigul, right? Secretary of IMA Dindigul, chairperson of the IMA Women Doctor Wings, and president of Dindigul Cosmos Lions Club. So any society in the Dindigul, she has almost served as a president or secretary of all the organizations. And more than 50,000, huge number of laparoscopic sterilization has been done in a period of only 3 years. That's great achievement, ma'am. This is your stage. We need your blessings. Please, ma'am.
Thank you, Doctor. That is good evening to all who have participated in today's Women webinar too. My salutes to the speakers, chairpersons, moderators, experts of the 3 topics, convener, coordinator, panelists, MOC, guest of honors, special guest, and all the participants of this program. My special and sincere thanks to Dr. Sarvas, the program director, who had called all the South Indian OB-GYN practitioners in a single platform. Happy to meet them all. It appears like a mini conference for me with the 3 nice topics. And we were being discussing in all the 3 topics. We were being discussing in a very, most of the conference we are discussing about this. The topics are selected in a very right way, early stage, that is the early pregnancy. If you skip, if you are going to the second trimester, then the patients can be very sure of their babies coming well. So the nice topics, nice speakers, and a nice director who has made this program. So I wish you all the best, and you should succeed in your contest for that committee, whatever committee you are contesting. And we also request everybody to vote for Sampath Kumari, who is contesting for the post of Foxy president from the south, and being a woman, we should give all our this thing to her, our blessings as well as the votes for her. Then we are going to conduct our TNFOG 4th annual conference at Kodaikanal. Which is a nice place in the south, and I request everybody. Almost 60 districts have joined in this program. 60 Tamil Nadu, from Tamil Nadu. I don't know how you gathered them all in a single platform. So salutes to you again, and I request all the doctors who are participating today's program. You should come for the Kodaikanal conference and enjoy to the core. It's a very nice thing. We have made lot of arrangements. You have not gone through such arrangements before, I think. In that way, we are making arrangements. So my sincere thanks again to Dr. Sarfaz and all the participants here. We are, thank you. Thank you.
Thank you very much, ma'am. One thing I just want to say, the love which has been given from all the societies of the Tamil Nadu, whomsoever I am calling or whomsoever I am inviting for this webinar, no one says nothing, no. Everybody was ready to join this webinar. So academic people are there in the Tamil Nadu. I love that. So after taking all the blessings from our guest of honors and our special guest, now it's time for the academic session for which we are waiting for.
Sarfaraz, only one point. Sarfaraz?
Yes, ma'am. Yes,
Yes,
please.
Madam will be taking over as TNFOG president in Kodaikanal, TNFOG annual conference.
Yes,
so I request all of people to register, and you spread the message to your friends. Kodaikanal is a wonderful place. June 5, 6, 7. All of you block the dates.
Definitely, ma'am. I will come, and I will come with lots of delegates and faculties. Sure, ma'am.
Thank you.
So whatever love given from Tamil Nadu should
I will
be
give back.
returned back.
Yes. I will give. I will return back with much more persons to involve in the Kodaikanal.
Yes. Okay. Thank you, sir.
Sure. Thank you, ma'am. Madhumita or Radhika, whomsoever, you now start for the academic session.
Yes. So moving on to the first session, we have a very interesting talk by our favorite Dr. Charmila Ayavu ma'am, who's a past vice president of Foxy on early pregnancy bleed and rational use of placenta supporting drugs. And we have a panel of highly eminent chairpersons. Can I have the CV, please? Dr. Jairani Kamaraj ma'am, who's a senior consultant of reproductive medicine, infertility and sexual medicine, and ma'am is also currently the chairperson of Foxy No to Violence Against Women committee, and she's also ma'am is the president elect of TAPIZAR and the joint secretary of TNFOG and the past president of OXY and co-chair of World's Association of Sexual Medicine. Next, we have Dr. Umayal Murugesan ma'am, who's the managing director of Sri Kumaran Specialty Hospital at Chennai, and she's the president of Kanjipuram Obstetric and Gynecological Society, and she's also the Foxy chairperson of Violence Against Doctors Committee and past president of IMA Tambram. And we have Dr. Chandra Ponnasamy, who is the founder president of Namakkal Obstetric and Gynecological Society, and she's also the executive council member of TNFOG. Dr. Meena Mahalingam, who's currently the secretary of Chennai Obstetric and Gynecological Society, and she's also she has numerous community participations to her credit. Next, we have Dr. Mala Raj ma'am, who's currently the vice chairperson of IAGE Tamil Nadu chapter, and she's also the founder secretary of IAGE Tamil Nadu. And she's been the managing council member of IAGE and the vice president of Chennai Menopause Society. And also she's currently the joint secretary of OXY and she's a secretary elect of OXY currently. We have Dr. Uma Maheshwari, who's the president of Virudhunagar Obstetric and Gynecological Society. And next we have Dr. Vijay Prabha Chelian, who is the secretary of Trichy Obstetric Gynecological Society and consultant at Shakti Hospital, Trichy. Jairani ma'am or Mani ma'am?
Yeah. Thank you, Madhu, for that nice introduction of the galaxy of chairpersons whom Surprise has kept for this wonderful topic. I have the great privilege and honor to welcome Dr. Charmila Ayavu, who is very well known for her caliber of giving a lot of academic orations, talks, and lectures. And she's the right person to talk on a very important topic that, as a fertility specialist, the first trimester bleed is really a nightmare for the fertility specialist and also the very saddest point for the patient. And definitely, we all know, as a patient's anxiety, we also anxious of what are the post first trimester bleed. It could be a miscarriage, it could be the preterm labor, it could cause a lot of IUGR, everything comes under this. So it is very important to throw insight about how we are going to prevent it, how we are going to support this term, and how we are going to give her a healthy future pregnancy is a real challenge. And of course, we know the magic drug, the progesterone is the one, but it is also very important how we use what is the latest study says. I think Charmila is the best person to talk about this. And we know well about her for her academic very superiority. She's the president of the Trichy OBGYN Society 2026-28 and the vice president of Foxy 2024 and vice president of Osteoporosis Society of India, secretary of Gestosis of Indian Association, and she's also a secretary of the academic wing of ART from Trichy. And she has very many publications for her, and also she has edited and authored very many books and articles, and had a very lot of international deliberations. We welcome you, Charmila, for your deliberation of this topic.
Thank you, Jairani ma'am. Thank you so much for that very, very kind introduction. I would like to wish Sarfaraz also. Thank you, Sarfaraz, for calling me for this important topic. I think it's not sharing. It's not opening?
No, ma'am.
No, ma'am.
Oh, ma'am,
Okay.
not opening.
One second.
Yes.
Ma'am, I have made you the co-host. I think now you can share your presentation.
Now it's seen? No.
Uh,
It was allowing me to share actually. Why is this happening?
Did you open your presentation and this on the side tab, ma'am?
Yeah, it's open.
I've made you the co-host.
Oh no, 1 second. I'll just close my Zoom screen. Why is it not sharing? I'll just go back and come now. 2 seconds.
Okay, ma'am, no problem. Till then, we just want to say that this is our second Well Women webinar series. We have started in 2025. First series has been completed in 2026. This is our 13th episode, and we are trying and we are always, in a way, involving all the distinguished guests and all the faculties from all over the different states in each and every webinar, so that we can learn something from this great academician of that field. And on this prestigious platform, I am seeing all of the dignitaries. I am welcoming some of my good friends like Dr. Sundar Narayan. Please welcome. Dr. Sarvana sir is also joining, Dr. Radha Madhuri ma'am, Dr. Priya, Dr. Purnima, Dr. Amala, Dr. Zairani ma'am, welcome. क्या हो रहा है? So I have contacted almost all the societies from the Tamil Nadu. Few societies, official people, president, secretaries were busy on this date, so they were not able to join. Rest, I have tried to include almost maximum societies for this webinar so that we can have a great academic session all together with all of you. We are wishing very best luck to Dr. Sampath Kumari ma'am for his candidature as a proxy president next year. And I am going for the chairperson of Ethics and Medical Legal Committee chairperson. So I also need your full support from all the societies of Tamil Nadu. The nominations will be on in May, and the election will be in August.
all the very best, sir. Looking forward. Kazi sir, I think your video is stuck. Mm.
Hello, Bhavna, everything is okay?
Sir, you got
Sir,
disconnected in the
okay
middle.
from our side. We are waiting
Okay,
for Chamila ma'am.
Yes, the Charmila ma'am said she'll send me the slides, sir. I'm just waiting. Once she sends
okay,
it.
okay. So she will send you the slide and then you can share.
Yes, sir. Yes, sir. I'm just
Just
waiting
like
for it.
that. Okay. Till then, Radhika, you can say a few words for this webinar platform as you are the coordinator for this series.
Sir, it's an immense, privilege and pleasure to be here with such a beautiful state society, Tamil Nadu, such beautiful ladies, dressed up so well prepared in their academics. And I must thank you and Dr. Madhumita and Deepika ma'am for including me with this little baby program of yours. More power to all the women of Tamil Nadu and lot of good wishes for Sampath Kumari ma'am. And all the best to you for your candidature for your elections, and I hope to see you in power and in position, Hela, and doing much more work with you. And thank you to each and every one of you who have joined, and thank you to all the viewers who are watching this who've registered for our webinar. A heartfelt thank you to all of you, and wishing you all the best, sir.
Thank you very much, Radhika, for all your support. And
I've
The
sent my
ma'am is back.
yes,
presentation to
yes, Charmila.
Madhumita. Like I'm asking her to share. I don't know. My
Yeah.
presentation is not opening in this window at all. I don't know what's going on.
Okay, no problem, ma'am.
Mm.
Till then, on the background, we can discuss about.
Yeah. So early pregnancy bleeding is something which is worrisome to most of us. So what I've actually taken down in the presentation is in early pregnancy, you don't have much of choices if there's going to be a genetic cause, but there are some causes which can be managed by certain drugs. So as the introductory remarks were being made, it's actually progesterone and HCG which are used in early pregnancy. So whenever you have a patient with early pregnancy bleed, the things you should first check for is whether the baby is viable and the hemodynamic status of the mother. So if the baby is viable, there are two drugs which you can use, and one is progesterone and the other is HCG. The logic of using progesterone is we know that when the
I've received. Sorry,
yeah,
ma'am.
please
I've
share.
received the.
Yeah,
Yes,
yeah.
ma'am.
Please share.
Can you please make me the co-host? I need to share Corona remedies. Can you please make me the co-host?
Bhavna, please do needful.
I've made you the co-host, Madhumita ma'am.
Yeah. Okay. I'll share the slides. Yeah.
I'm extremely sorry for that, Dr. Kasi.
No, ma'am. It's okay. Because I have also tried before coming. Yeah, now it's visible.
Yeah,
Yes. Yes, ma'am.
make it into screen share. So slideshow.
Yes, ma'am. Is it?
You have to right, yeah.
Yes.
Yeah.
Next slide, please. Next slide. Next. So early pregnancy bleeding, as I said, is a common but a very clinically important symptom. And when you want to manage such a condition, you need to know the cause, the severity of the bleeding, and of course, the viability of the pregnancy. Next, Madhu. Madhu, next slide, please.
Yes, ma'am. Just it's not moving.
Just click on that and then go. Probably it will go.
Yes. Yes, ma'am. Yes.
So when there's a early pregnancy bleeding and it's less than 12 weeks, you need to know the cause. And the commonest cause is often threatened miscarriage. That threatened miscarriage means the os is still closed, the pregnancy is viable, but she's having pain or bleeding. Subchorionic hematoma may be a reason. Ectopic pregnancy should always be ruled out when you have an early pregnancy bleeding. It can be a missed miscarriage or an incomplete miscarriage. And there are previous slide, please. Cervical causes like erosion, polyp infection should all be ruled out when you have an early pregnancy bleeding. Next slide. So when you want to manage, first assess the mother's hemodynamic stability, confirm whether it's an intrauterine pregnancy, and the most useful ultrasound for this will be the transvaginal ultrasound. Check the viability of the fetus, and the lab investigations for hemoglobin, blood grouping, and RH typing should be needed. And suppose there is a doubt, then probably you'll have to do a serial beta HCG if there's no pregnancy which is being identified. Next. So the placenta supporting medications which can be used, and particularly it can be used in threatened miscarriage with a viable pregnancy. Out of that, progesterone is the most important, and the second important agent is human chorionic gonadotropin. Next. Next. So those drugs are definitely used, but there is a selective use for tranexamic acid. Still, there is no recommendation as far as the first trimester is concerned. But we have been using when there is no other remedy for mothers who have got persistent bleeding episodes in the first trimester. And the drug which you can use is tranexamic acid. It is an antifibrinolytic, so it can reduce the bleeding. There's no evidence as far as early pregnancy is concerned, but it's more established for postpartum hemorrhage, which was showed in the women trial. It can be used if there's a significant bleeding, but it's not a standard for a routine threatened miscarriage. Next. So the hematinics also will give an indirect support to the early pregnancy, and that is because it's very important in India because of the high anemia prevalence which we have, and it will support the maternal oxygen delivery if you're maintaining the hemoglobin status of the mother, and that's where it can probably indirectly support the placenta. Next. So the progesterone is a main drug which is used for an early pregnancy bleed, and the name itself tells you it's a progesterone. So it's needed for creating a suitable endometrial lining for an embryo implantation and further growth of the embryo. Next. So how does it work during pregnancy? It's an essential hormone needed to maintain pregnancy, because you have seen when you give antiprogesterones like mifepristone, it's going to terminate the pregnancy. So the other way, when you give progesterone, probably it will help to maintain the pregnancy. After ovulation, we know that the endogenous progesterone is being produced by the corpus luteum. And suppose no fertilization occurs, the ovarian progesterone production by the corpus luteum falls. That will trigger an endometrial shedding and the mother menstruates. But suppose the ovum is fertilized and it implants into the endometrium, the corpus luteum continues to secrete progesterone to prevent endometrial shedding, thereby protecting the fetus. Later in pregnancy, the placenta takes over progesterone production, a switch that is regulated by HCG. Next. And as I said, progestation means for pregnancy, and it also works by regulation of cellular immunity, and that it works by mediation of the uterine blood flow, and it improves the uterine endothelial adaptation to pregnancy by increasing the nitric oxide production. And when there's a drop in progesterone, we know that is possibly one step that facilitates onset of labor. So when you give progesterone, it may help to maintain the pregnancy. Next. So progestogens, when you use, it can be a natural drug or it can be a synthetic preparation. When you call it as a natural progesterones, they actually chemical structures that are likely produced by the body and is available as a micronized gel or pessary. The synthetic progestogens which are used as for management do not correlate with natural progesterone and are artificially manufactured in a laboratory. The examples of synthetic progestogens are injectable 17-alpha hydroxy progesterone caprolate and oral dydrogesterone. And natural progesterone will suppress myometrial contractility, unlike 17-hydroxy progesterone caprolate, which does not have this effect, and at high concentration may actually stimulate the myometrial contractility. Next. So when you give intramuscular progesterones, it means you're bypassing the first pass metabolism in the intestines and liver. And that's why there may be a very high circulating progesterone levels in the circulation. And this level is actually will be maintained for a longer duration compared to a vaginally administered progesterone. But still, there's no clear evidence to show that just because you have got a higher serum level of progesterone, it will translate to an improvement in a successful pregnancy rate. And up to this time, no trial has reported a long-term follow-up of progesterone treatment in recurrent miscarriage. And that's why the long-term safety of progesterone supplementation is still not well known. But what is quite heartening is there is also no evidence to show that progesterone causes an anatomical or a physiological abnormality in a fetus. So it's quite safe to use as far as the studies are concerned up to this point of time. Next. So how does progesterone work? The main method of action is through the immunomodulatory mechanism, and it will there's a change in the T helper cells 1 and 2 paradigm. So when you have progesterone secreted in an adequate amount in the body, it will inhibit the production of T helper cell 1 cytokines, and it will upregulate the production of T helper 2 cell cytokines. That means when you have a normally progressing pregnancy, it means the T helper cell 2 cells are predominating compared to T helper cell 1. And one action is by the production of cytokines, which will upregulate Th2 cytokines. And the other mode of action of progesterone is by producing something called a progesterone-induced blocking factor. So when you have an adequate amount of progesterone inhibiting blocking factor, you will have more of T helper cell 2 levels, and that will help in a normally progressing pregnancy. And progesterone is supposed to stimulate the production of progesterone induced blocking factor, which induces a Th2 response, and it will downregulate the natural killer cell activity. You have to go to screen. What happened? Adumita. Really sorry. Madhu?
Adumita?
I think her thing went off.
Hello? Adumita?
So there are some questions in the chat box. I'll answer by the time she joins.
Yeah.
So
I will call.
Dr.
I'm calling.
Dr. Manjula has asked, like, can oral iron be allowed in the first trimester of pregnancy? It is actually not advisable as far as recommendations are concerned. What I meant was, if you keep the anemic status, if you keep a hemoglobin status at a good level, it may actually help in the prolongation of pregnancy, because you need an oxygen support to the developing fetus. So when you have a good hemoglobin status, and suppose the patient is severely anemic, we know that you have to, you have to maintain her hemoglobin status, and oral iron is not actually allowed in the first trimester as far as recommendations are concerned, but we have been giving, and there are no actually problems with giving iron, but still there are no recommendations for that. Madhu, please make, you have to go ahead. Before this. Yeah. So when you have both a good number of T helper cell 2 and you got a progesterone-induced blocking factor, you're going to have a normally progressing pregnancy. But when there's a deficiency of progesterone, or the production of progesterone-induced blocking factor is less, it's going to tilt towards more of T helper cell 1, and that is going to cause the pregnancy to go for a miscarriage or abortion. Next. So what are the indications of progesterone in obstetrics? Recurrent pregnancy loss, and as I talked about, a threatened miscarriage, can be used for short cervix and for prevention of preterm birth. Next slide, please. So how does it work in recurrent pregnancy loss? It has got a similar mode of action as in threatened miscarriage. The pivotal role in recurrent pregnancy loss is the progesterone receptor mediated immunomodulation. And as said, when you have enough progesterones, you are going to have a pre-implantation factor which is secreted well, and that will cause an increase in progesterone-induced blocking factor at the decidual level and at the peripheral level. And so what happens is, this is sufficient to form more of the T helper cell 2 and the asymmetric antibodies Th4, as well as the NK cells, which will become much more, and that will actually lead on to a fetal production and the delivery of the baby in a term condition. But when you have an insufficient PIBF because of progesterone reduction, that is going to cause bias towards Th1 cells, and that is going to cause more of an cytotoxic inflammatory reaction, and the patient can go for a abortion. Next slide, please. So the studies there was a study in 2022 which said progesterone may play a role in preserving an ongoing pregnancy, but it should be a non-genetic cause of threatened abortion. And the way it acts in threatened miscarriage is an extra endometrial immunological protective effect, which I talked about earlier. There's also a myorelaxin action which progesterone has, and that can help in maintenance of a pregnancy where there's a bleeding episodes. And that's why they've recommended progesterone in the treatment of patients with threatened miscarriage. Next. So there was a study in 2020, and it was actually by a very good group led by Dr. Kumarasamy. And they did an analysis. They said there's a very small effect, but a very positive effect, which is dependent on the number of pregnancy losses. So suppose there's a dual risk factor for a patient. That is, she's having a bleeding, and she's having a history of a prior pregnancy loss. And this patient is the one who will actually have much of benefit when you give progesterone. Next. And the dosages is always a confusion. We talk about IM dose, subcutaneous dose, vaginal dose, and all that. But there was one study which was brought out by the eminent obstetrician Jayam et al., and that was published in 2022. So suppose you have a patient who is having a vaginal bleeding, and she's also giving a history of a prior pregnancy loss. You give at a dose of 400 milligram twice daily, starting at the time of presentation of the vaginal bleeding, and you have to continue until 16 completed weeks of pregnancy. And suppose she's not having a bleed at all, but she's having a history of 3 or more previous losses, you can start at 200 milligram twice daily, and you can continue until 12 completed weeks of gestation. And suppose you started at 200 milligram twice daily, and she's suddenly having a bleeding episode in spite of the 200 milligram twice daily, you can increase it to 400 milligram twice daily, and you can continue until 16 completed weeks of gestation. Next. And Eshrey, what it has said recently is, as progesterone is very important during implantation of the embryo, benefit from a supplementation may be much better if you started from the luteal phase for a patient who has got a bad obstetric history earlier, like a pregnancy loss earlier, and you do not want her to bleed during pregnancy. You can actually start it in the luteal phase rather than waiting for a positive pregnancy test. And vaginal progesterone may improve live birth rate in women with 3 or more pregnancy losses, and is now having a vaginal blood loss in a subsequent pregnancy. So what actually all the studies said was, when there are more than two to three losses, when you give progesterone, it actually has a much better benefit. And as Eshrey said, you can actually start it in the luteal phase and have a luteal phase support also, and then continue it during pregnancy rather than waiting for the positive pregnancy test. Next. And according to the American College of Obstetrics and Gynecology, and what they said in 2023 is, you can give progesterones for the prevention of preterm delivery. And that is very important when there's a history of preterm birth. And now when you've done an ultrasound and the patient is showing a short cervix with a singleton pregnancy, and they consider vaginal progesterone as the mode of therapy for such patients. Next. So what about intramuscular 17-hydroxyprogesterone caprate, which we have been using for a long time? According to the American College, it's now not recommended for the prevention of recurrent preterm birth. And their use of 17-hydroxyprogesterone caprate is not accepted, as it was not found to be of any use in the general pregnant population. And its use in a specific group is being actually evaluated now. And the FDA has not based its decision to stop the recommendation because of any safety concerns. They've actually based the decision on the fact that this drug is not working as a drug for prevention of preterm birth. So this drug is quite not useful, so why use it? But I think in our country, we still use it in a big group of people, and we are having some benefit. Because this you have to take in the context of the first trial, which said that this drug is useful, said that 17-hydroxyprogesterone caprate works in a population where they had a black population. And when they did the subsequent study, it was done in a white population. So in the white population, it did not show a benefit, and that's why FDA said it's not useful, but it was quite useful for the black population, and that's why it's translating to good results for us in our Indian subcontinent, I would say. But FDA is not recommending it for the use of prevention of preterm birth. Next. What about HCG, the second drug? It's a glycoprotein hormone, and it's produced by the syncytial trophoblast, and it is detected 6 to 8 days after fertilization. It is very useful for early fetal development through its role in implantation and establishment of the maternal fetal circulation. It is widely used in reproductive medicine, and its role as a therapeutic component in obstetrics is quite limited and highly specific. So do not think that beta HCG will be a very good drug as far as management of early pregnancy bleeding is concerned. Next. So the way it acts in early pregnancy is it's involved in the preparation of the uterine wall for implantation and maintenance of the corpus luteum. It will help in angiogenesis and vascular remodeling. It will help in the immunomodulation to facilitate invasion of the uterine wall without a fetal rejection from the maternal immune system, and can also help in the growth of the uterus in accordance with fetal growth. Next. In a large study in the first trimester, they said when you have low HCG levels, it was associated with intrauterine fetal death. And when there were high HCG levels, it was associated with preeclampsia. In the second trimester, in contrast, high HCG levels were associated with both IUFD and PE. And there was no strong association in the second trimester between pregnancy outcomes and low HCG. So it is quite contradictory, but that's why HCG may not be a very good drug for the management in first trimester. Next. So what is the indication for HCG if you want to give? It's a very good drug for luteal phase support. It's very important in early pregnancy until the placenta takes over at 8 to 10 weeks. The dose you give it is 1,500 to 2,000 international units IM every 3 days until 8 to 10 weeks. In recurrent pregnancy loss, it will promote Treg cells. It can reduce NK cell activity and can enhance trophoblast invasion. But still, the evidence remains inconsistent for recurrent pregnancy loss, and it's not a guideline-based standard therapy. As far as fetal growth and placental function is concerned, there's a proposed role in enhancing angiogenesis and preventing early placental insufficiency, but still it's not a standard clinical practice. In threatened miscarriage, you can give it at a dose of 1,500 international units IM twice weekly for 2 to 3 weeks, but the evidence is weak for this also, and that's why you can use selectively. Next. So what is the recommendation as far as the guidelines are concerned regarding HCG for any placental issue? NICE Guidelines 2021 said progesterone should be preferred over HCG in threatened miscarriage. American colleges said there's no routine recommendation for HCG in miscarriage prevention. And RCOG says there's a limited evidence for HCG therapy in RPL. Next. These are my references. Next slide, Madhu. Thank you so much, Madhu. I know I put you to trouble, but thank you so much for that. Thank you, Dr. Sarfaraz. All the best for your future. We are there for you. Thank you. You can stop sharing.
Yes, ma'am. Chairpersons for your closing remarks, ma'am, please.
Mala is there? Who else is here?
Vijay Prabha is there.
Thank you.
Vijay Prabha ma'am is there.
Yeah. That was, as usual, a very clear, concise, and to the point, evidence-based discussion on progesterones and HCG and the support system for the early pregnancy loss. Like I just have one question. In one of your slides, you mentioned that 17 hydroxyprogesterone promotes myometrial contractility.
Yeah.
Whereas the vaginal, the micronized progesterone inhibits the myometrial contractility.
Yeah.
What is the dose of the 17 hydroxyprogesterone which promotes myometrial, it stimulates myometrial contractility?
Actually, there's never been a recommendation of giving 17 hydroxyprogesterone caprate in the first trimester. If it's given, it should be given after 16 weeks of pregnancy. If you give it early, they say it can increase a myometrial contractility and can actually not help in maintaining a pregnancy. So it should not be given at all. And vaginal progesterone, on the other hand, they say when you keep it as a vaginal dose, it will actually prevent the shortening of the cervix and also will have a myorelaxant action. And it's very contradictory because it's all the Western papers. They keep on changing among themselves. Once they say oral progesterone is good, and then after a year, they say vaginal progesterone is good. Then they say this IM progesterone is not good. So what I would say is our studies are not so much that we can give a recommendation. But I think at this point of time, we all give oral progesterone and it works quite well. As far as when there's a threatened miscarriage, I would be very scared to put a vaginal progesterone for a patient who's already bleeding and she may not keep it also. And I don't have a option of giving an IM progesterone for a long period of time because I don't know like how long the patient can have a painful injection like that. And the subcutaneous progesterone we have been using, but we don't have data to support us to say that it definitely works. So at this point of time, I would say oral progesterone, which has been accepted by the ISHRAE guidelines last year, 2 years back, but now there are no change to vaginal progesterone. I think still oral progesterone has a good role in maintenance of pregnancy in early pregnancy bleeding.
So I would like to add up certain things. We had a FOXY conclave regarding the first trimester bleed with a dydrogesterone as it is. Dydrogesterone has been given, it should be given in a threatened miscarriage where there is a
4 tablets
30 milligram stat dose. So that has an important, they have one study. There are few studies which says that 30 milligram dydrogesterone can prevent a subchorionic hemorrhage, especially the first threatened miscarriage there can prevent, and there are some studies related to it. So definitely,
Madam,
it-
no, madam, what we have done from our country, they are not accepting at the international level because they say still it's insufficient. And now that's what in yesterday guideline of 2022, if you see, they talk about oral progesterone, they talk about dihydrogesterone, and they have again changed their mind and now they're talking about vaginal progesterone. So our study was not accepted so much. I'll give you a call to tell you why it happened. I'll give you a call
yeah,
personally.
sure. So all this, but there I mean, we are using, I find out a little better improvement over this because already the patient is on, in a case of an IVF or an ART patients, when we give them already with a vaginal micronized, it is very difficult for them to accept it when they have a threatened miscarriage.
Yes, ma'am.
So in that way, when you give an oral, we find that there are some good amount of improvement and the pregnancy improvement is very good. So definitely we may need a lot of proper study.
Yes,
I mean,
ma'am.
as you rightly said, we should have a proper RCTs
Yes,
and I mean, we should do a big study. Then
Yeah.
probably we can present our
Yeah.
thing to the international forum. And definitely we cannot say that our people is the same with the Western. We
Yeah.
must be having every people have their lot of changes in the immunomodulation because this progesterones not only have an effect on the support, luteal phase support, it has an immunomodulation.
Yes,
That is
ma'am.
what they say. This immunomodulation play a very important role. As you rightly pointed out, the progesterone level, the T helper cells one
there is
and two.
no, there is actually a study which also says when you give progesterone, it can actually reduce a chance of preeclampsia also because of the immunomodulatory effect.
Immunomodulatory effect, yeah. So this immunomodulatory effects play a very important role in the implantation, right from your RAF and also to the RPL. This has a very wide use, and many of this nowadays, that is the main topic that they are looking into, the immunomodulation and the immunity regarding the RAF and RPL. So definitely progesterone has a role. Probably we may have to bring our studies from our side or
Madam,
set up
I don't know about your experience, but somehow I find subcutaneous aqueous progesterone quite good, and it can stop the threatened miscarriage bleeding in many patients. How is your experience about that?
No, they're already on intramuscular progesterone.
No, madam,
So when,
aqueous progesterone is less
yeah,
painful.
I know. Less painful, I agree. But still, when we are using already when progesterone parenteral. So when they are on the parenteral use, there's no point in converting them to a subcutaneous.
We don't give oral. We don't give parenteral. We usually give a vaginal gel, and when she bleeds, we just switch over to aqueous progesterone, and that seems to be much better. We don't give parenteral routinely. It's only when she has a bleed, we switch over from the, that's what I say.
Because that depends upon the patient compliance, because many of the patients, they won't put the gel proper. So we never rely on the gel,
but
especially only for few patients, not all. So it all individualized. Nobody, it is not hard and fast like that. So, but definitely this 30 milligram dihydrogesterone has a, I mean, definite improvement is there when they have a threatened miscarriage immediately after 6 weeks or 7 weeks or 8 weeks.
Madam, when you become TAPISAR president, do that study, madam, for us.
Yeah, sure, with pleasure, with pleasure.
Yeah.
We need all your support. Everybody can do. We can do as a multicentric
please
trial.
take us.
We'll do a multicentric trial.
The same group you can utilize. All of us are there.
Sure.
Yeah, definitely.
Thank you, sir. First, thank you for
Thank you.
making a big galaxy of the TNFOG here. And it's lovely. I mean, I really appreciate you for all your efforts. And definitely your efforts will be rewarded by a grand success in the election.
Thank you very much.
Wish you all the best, Sarfraz.
Thank you. Charmila ma'am, thank you.
Yeah, Chandra Ponusami madam is there.
Madam is there. Chandra madam is there. Madam, your words.
Yes.
She's a Jambawan. She's a Jambawan in IVF here in Tamil Nadu.
And what about Chandra? I wanted to, it's a wonderful talk, but I want to ask whether prophylactically can we, because Isha says that luteal phase we can start progesterone.
Yes,
so for IVF patients and all, we are giving progesterone.
Yes,
so what is your idea for giving prophylactic progesterone instead of waiting for the patient to bleed?
That's what Dr. Jayarani madam also was talking on. We give progesterones routinely, and in the context of IVF, we have been giving. So you can give it in a patient who's having a history where she has had a previous miscarriage in the first trimester, and you know it's not a genetic cause. It's worthwhile giving in the luteal phase itself, because the support has to be there when the embryo is getting implanted. And when there's a rejection at that level, this pregnancy may not grow. So I would say it's quite good giving for patients with a history of a pregnancy loss. Not for everybody, But when there's a history of a pregnancy loss and she's had a threatened miscarriage earlier and then she went for a termination, I think it's worthwhile giving.
And I wish Dr. Sarfraz success
Yes,
in
ma'am.
your
Thank you very
exam.
much, ma'am.
And also Dr. Sampak Kumari, whether she's here or not, I don't know.
Dr. Mala is also contesting, we forgot. She just left. She is also contesting for
I wish her
endometriosis or
also
something. Yeah.
all the best. And Dr. Madhumita also for the ECE membership.
Yes, Madhumita is also contesting and she's already through.
Yes. She's
Midlife is next year.
she's preparing for next year.
Next year.
Okay, thank you, ma'am. Thank you, Charmina,
Thank
ma'am. Your
you.
wonderful and concise talk and
Thank you.
for understandable with evidence-based. As we all knew that progesterone will come in different forms. It all depends on how our patients are compliant with that and how our experience tell us in to use which progesterone. We cannot say this progesterone is based. We can move on from vaginal to oral. Sometimes we move on from IM. It all depends on how our patients are compliant and how good results we are getting. Thank you very much, ma'am, for your talk, for your presence. Thank you, ma'am.
Thank you, Sarfraz. Thank you.
Madhu, the next session.
Yes. So after the end of the wonderful first session, now we move on to our second session, for which we have our speaker, Dr. Sarfraz Kasi, talking on rescue cervical cerclage, preventing the unpreventable. It's with a video presentation, and we have a panel of eminent chairpersons. Dr. Sundar Narayanan. Sir is currently the president of Nagarkoil Obstetric and Gynecological Society, and he's also the endoscopy committee chair of TNFOG, and he's a very renowned endoscopic surgeon in Tamil Nadu, and he's also a committee member of Infertility and Environmental Committee of FOXY. Next, we have Dr. Chandrakala Maran, ma'am, who's the president of Coimbatore Obstetric and Gynecological Society. Ma'am is also the HOD of KGPG Medical Institute in Coimbatore, and she's also the organizing chair of Your Foxy South Zone last year. Next, we have Radha Madhavi ma'am, who is the founder president of Tiruvannamalai Obstetric and Gynecological Society, and she's also the joint secretary and executive council member of TNFOG. And we have Dr. Rajalakshmi, who's the secretary of Tuticorin Obstetric and Gynecological Society, and she's currently assistant professor at Tuticorin Medical College and Hospital. Dr. Dhanalakshmi, MG Dhanalakshmi ma'am, who's a professor and senior consultant at Ramachandra Medical College at Chennai, and ma'am is also the president-elect of Oxy Society, Chennai. Dr. Gayatri Sivaramakrishnan ma'am, who's the secretary of Tirunelveli Obstetric and Gynecological Society. And Dr. Radha Lakshmi, who's currently the secretary of Virudhunagar Obstetric and Gynecological Society. Over to the chairpersons to introduce the speakers, Sundar Narayanan sir and Chandrakala ma'am.
Hello.
Yes, ma'am.
So, very good evening to all of you all. I got to hear the previous lectures, really wonderful and a very nice interactive session also following. And here we are to hear Dr. Sarfraz Kazi, who's going to give us talk on rescue and cerclage. It's something which is, it's a very intriguing subject, and then we would like to hear as to what sir's experience in that. And sir is the director of Najiwan Women's Hospital Research Institute, Himatnagar, Gujarat.
Ma'am, okay, already introduction has been given, and
Yes,
we are
okay.
also
Welcome, sir. Welcome.
yes, sir. Thank you very much. Thank you
Yeah.
very much, all my chairpersons on this prestigious platform.
I want to add a vector plus.
Yes, Sundar sir, please.
Yeah. You are very close to my heart. Yes, since the way we first met, and often we see in almost all the conferences, he's a very enthusiastic and energetic person. Okay, in spite of all his schedules, he keep on attending all the conferences. He's very much involved in all the academic activities also. And I wish you all the best in your future endeavors as well as the coming elections, sir. For us, you can carry on.
Thank you very much. Thank you very much, Sundar sir. Thank you very much. Is my screen visible to everyone?
Yes.
I have to make it full screen. Now it's okay?
Yes.
Yes, sir.
Okay. Thank you very much. So my topic is rescue cervical cerclage. I will not go in detail about all this literature work, I will directly, first of all, I am bringing greetings from the land of truth and unity, the land of Sardar and Gandhiji. Briefly, I will describe the cervical incompetency or cervical insufficiency is a defect in the structure or function of the cervix that causes it to fail to retain or contain the fetus intrauterine till the viability of fetus, and which creates the condition called cervical insufficiency, in which cervix ripens and dilates with or without uterine contraction, and the occurrence rate of cervical insufficiency is maybe 0.5 to 1%, but the risk of reoccurrence is as high as 30%. What diagnosis test you will do to know whether this patient will go for the cervical insufficiency or not? Sometime ultrasonography, sometime hysterosalpingography, and mainly the reason for early pregnancy or mid-trimester pregnancy loss is the infection either by chlamydia, gonorrhea, mycoplasma, or bacterial vaginosis. This must be treated whenever you are dealing with any pregnancy loss patient. What interconceptional period treatment you can offer if there is a uterine septum, or if there is a submucous fibroid, or if there is a biconate uterus, surgical correction should be offered to all the patients. And each and every patient should be treated with the antibiotic for the genital tract infections, mostly by the doxycycline or erythromycin, which is cost effective also. Recently, newer technique developed for the interconceptual laparoscopic cerclage, in which 5 mm Marcelin tap is being used to tighten the cervix at or above the level of internal os before the planning of the pregnancy, and it also giving the very good result when it is done with in interconceptual period. So what can you offer the patient if a patient will come with the dilated cervix and membrane bulging in cases of cervical insufficiency? Non-surgical method, bed rest with tocolysis you can give. And surgical method include technique of cervical cerclage. Normally we are using this technique, which places the stitches above the opening of the cervix at the level of internal os, with the goal to reinforce the muscle tissue of the cervix and tighten the opening of the cervical canal. Largely, we are using McDonald's. In some cases, some refractory cases, we have to go for the Searle curves. These two tactics are used by most of the gynecologists. Cervical cerclage is one of the standard options of prophylactic intervention in the care of women at risk of preterm birth and second trimester fetal loss. This procedure was first performed in 1902. When will you advise? Either history indicated, as Madam suggested, that 2 second trimester abortion with or without any fetal pathology. Ultrasound indicated if there is a consecutive decrease in the cervical length starting from 2.5 centimeter. So which gradually decrease in subsequent scan, then you can offer cervical cerclage. What is rescue cervical cerclage is a salvage measure in the case of premature cervical dilatation with bulging of membrane in the vagina. What findings you will found on ultrasonography, cervical length less than 25 mm, but it is not a criteria. Cervical funneling or protrusion of the membrane, presence of fetal parts in the cervix or vagina with membrane. What are the prerequisites for and pre-surgical procedure for cervical post-heading? Extensive and comprehensive counseling must be done, because you will not get 100% results in each and every cases of rescue cervical cerclage. If required, neoplasia screening should be done, and infection must be treated priorly, and timing should be at least after anti-scan report comes normal. And as hydroxyprogesterone caproate in second trimester, we can give as Charmila ma'am suggested. So this is our case presentation, a 32-year-old Gravida 2, one history of abortion, which is referred to our center by a colleague in the emergency with the complaint of bloating, heaviness, and pain in lower abdomen, with history of previous 1 abortion and 8 weeks, and this is her IVF conceived pregnancy. Routine examinations were done by the colleague, and her antenatal care were normal with no history of previous urinary or vaginal infections. Prophylactic cerclage already has been done by the colleague at 14 weeks due to the cervical length less than 2.5 centimeter and the previous pregnancy. TIFA scan was normal at 22 weeks, but at that time the cervical length decreased to 22 mm. As such, patient's vitals were normal, fundal height correspond to the gestational age, and look at here, the PV findings are sketchy. cervix 4 to 5 centimeter dilated, 60% effaced with membrane bulging. And the patient was admitted to the hospital for emergency cervical cerclage. Blood test, serological examinations has been performed. Vaginal culture was taken, which found free of infection. Betamethasone was administered and progesterone has been given. This was the case when patient came to us, and this is the procedure which we have done in this case. Sorry. So this was the situation when we encountered the patient at our labor room. Normally, we are doing this procedure under regional or general anesthesia. This was the situation. Beforehand, we had given the patient atosiban. I am preferring in this type of cases atosiban mainly. This is the previous stitch, which is coming down a lot. We have to remove that stitch first. See, atosiban is giving very good tocolytic effect and uterus become very relaxed. So it is very useful for us to push back the membrane. We are using Foley's catheter 22 number. With this, we are pushing with inflated bulb. We are pushing the membrane. Again, I will show you. This is the inflated police bulb with which is inflated up to 50 ml. And according to the size of the membrane, we are inflating the bulb. Once we are able to push the membrane inside the cervical cavity, and once we are confirmed that there will be no back pressure, we increase the inflation of the police catheter bulb. We can inflate this bulb up to 150 ml also. There is no risk. So assistant is inflating right now the bulb so that the bulb will occupy all the cervical cavity area and the membrane will not come out again while taking cervical stitch. Once we are confirmed, we push the Foley's catheter above the level of the internal os. And then we will start with our routine McDonald stitch process. Any non-absorbable suture material like ethylone or Prolene or silk you can use. I don't know, but somehow I am very much comfortable with the silk because it didn't cut through. Though a few reports have suggested that there are more chances of infection with the silk. 1 or 2 number, whatever you feel comfortable. So as high as possible, you have to take the McDonald stitch. See, we are almost 1 centimeter ahead of the previous suture. Double thread we are using so that it will give the more compression and more strength to the pushing membrane. Some people are using the technique to fill the bladder 500 ml before doing this process. We are not using that technique. 2 number silk is routinely used by us in most of our cases. The important is very good assistant, very good anesthesia, and definitely prior proper counseling must be done because, as I said, all the cases are not 100% successful. Though luckily we have very good study of few cases at our center in which we are getting more than 70% positive results, and we are able to continue the pregnancy till the viability. Almost all cases around 32 to 34 weeks. So at this stage, we have to start tying the knot, but we will not tie entirely because our bulb is inside the uterine cavity. So once I start tying the knot, my assistant will start to deflate the bulb slowly. Till then, I will not tie fully. I will keep my position on tying knot, and my assistant will do the rest to deflate the Foley's bulb. And once Foley's bulb is completely deflated, This will give us the security that the membrane will not come down while tying the knot. And now I will tie fully, and rest of the process we will do like this. I will show you the final picture. This was the patient which we have delivered by cesarean section. This patient also got admitted for 7 days. Routinely, we are keeping this type of patients for 7 days with good coverage of antibiotics. As this is the final picture, and luckily we were able to continue this pregnancy till 34 weeks. And this is the second case. This is the second case recently we have done. In this case also, a history of 3 previous abortions has been done. No live child, and this was her 4th delivery. She came at 26 weeks with this condition, with the bulging membrane. There was no pain at that time. Same technique we have included. See, one more thing I forgot to mention, the position of the patient must be stiff tendon position, so that we will get good exposure also, and the membrane will become loose with the effect of the position and the tocolysis. And then we will repeat the same process, and with the pressure of the Foley's bulb, we can push back the bulging membrane inside the uterine cavity. Sometimes it is not possible for us to catch both the lip of the cervix. So in that cases, we are catching only anterior lip, and we are trying to push the bulb inside, and then we will catch the second lip. So here also we are tying as high as possible. The same McDonald's stitch with the same silk suture. This patient is still having 30 weeks pregnancy, still not delivered. Luckily, she survives this incident. Some of the cases we have to deliver due to the prom, even if we will take this stitch. So the same thing, you have to deflate before tying this stitch tightly. And once you deflate, then you finish the procedure. So this was the case presentation, one case presentation. Everything has been discussed. Protocolysis, atosiban, patient should be placed in stiff tendon positions. Everything has been discussed during the video. Atosiban maintenance dose continue for 12 to 24 hours. Then you can switch to the another tocolysis, because first 24 hours are crucial. 7 days antibiotic, daily blood investigations. This patient came again after 1 week. The patient showed no post-operative complications and patient discharged, but again it come after 28 weeks, where patient reported a mild abdominal pain and was admitted and controlled by the injectable tocolysis. And at 34 week, patient delivered by cesarean section due to rupture of membrane. So you can say the rescue cervical cerclage is controversial, but its advantage outweighs the risk. While it can be used to continue the pregnancy to ideally viable weeks of the gestation and conquer to a positive outcome of pregnancy, exposing the membrane of the fetus to the vaginal flora carries the risk of infection. In our case, we performed this cerclage at 24 weeks, and there are no post-operative complications, and patient delivered at 34 weeks. What are the contraindications? As routine cerclage, active bleeding, active contraction, which not respond to the tocolysis, premature rupture of membrane, proven case of the chorioamnionitis or anomalous fetus. Risk are always there. Chorioamnionitis, preterm labor, rupture of membrane, cervical lacerations can occur. What advice you will give at the time of the discharge? Usual antenatal advice and periodic USG for fetal monitoring. pelvic rest, no intercourse, no dosing to avoid weightlifting and rough journey, complete bed rest and foot and rest for few days, and to report if there is any complaint. So in conclusion, cervical insufficiency is a condition that can lead to preterm delivery or worsen to miscarriage, and rescue cervical cerclage is a procedure that, while it carries risk and can aid in the prolonging the gestational age to the viable age. There is a debate what to do or what not to do, but it is always better to do. More research regarding this issue could aid in the treatment of future cases of cervical insufficiency. Discussion, serial measurement of cervical length can be used to under ultrasonography image, and the effect of cervical cerclage on women who present bulging membrane and cervical insufficiency have been well documented. The use of this technique is very crucial with the expert hand to extend the gestational age to the viability. And in addition, performing cervical cerclage in populations at high risk of preterm birth has the effect of significantly lower perinatal morbidity and mortality. Survival rate of the fetus of an expectant mother with rescue cervical cerclage is reported to between 48 to 68%. This is our study, total 21 cases since last 5 years. With 4 to 7 centimeter dilatation and bulging of membrane. Among that, 18 cases have reached to the viability. 3 cases end up with the complication, 1 lost to the follow-up. These are the references. Thank you. So the take-home message is, in any critical circumstances, option of intervention should be offered to the patients and be chosen by clinician rather than doing nothing. Thank you. Thank you very much. As I told, contesting for the post of Ethics and Medical Legal Committee chairperson for this year. Nomination will start in May and the election will be in August. Please remember me at the time of nomination and at the time of voting also. Thank you. Thank you very much.
Thank you so much for the wonderful talk, sir. Can we have closing remarks from the chairpersons, please?
Yes, yes.
Thank you, Dr. Sarfraz, for including me into this webinar. You are very lucky to have so many good cases and all the time, but it is very stressful in such cases and lot of counseling is needed. And all the best for your election. And thank you very much. It was a good presentation.
So it was a wonderful presentation. The video was so good and neat. And the important tip, we have to inflate more saline after from 50 to 150 ml. It was a very important technique for me actually. And then I have a question, sir. Do you recommend routine cervical cerclage for twin babies? And if even if the cervical length is normal, and do you recommend routine cerclage for polycystic ovaries patients who have conceived with single-term pregnancy?
No, ma'am. Not routine for all. Until or unless it is indicated, if in a twins pregnancy, if we found that cervical length is too short, we will counsel the patient. In IVF or a very precious pregnancy in twins baby, we counsel the patient regarding the benefits of the routine cervical cerclage. If they are agree, we will go through. Otherwise, in normal cases, according to the indications, we proceed.
What? Excuse me. Hello.
Yes, ma'am.
Can I speak?
Yes, ma'am. Meena, ma'am.
Yes, ma'am.
Vinuta, ma'am. Yeah.
Yes. Yeah. That was wonderful, Dr. Sarfraz. A lot of information we collected today. Yesterday, I had the same case. She was my niece. She had conceived by IUI, and unfortunately, she went for anomaly scans, absolutely with no any symptoms. And on anomaly scan, they diagnosed. Our radiologist, she called me and she told me like this girl had come for anomaly scan. There is full dilatation, and she said like she has done a PV. There was membranes were bulging. I was so shocked. She just went for anomaly scan and that was diagnosed. She came back to our hospital and I did the same procedure as what you showed. Like, but unfortunately, the cervix was very thin, and I couldn't push the membranes to the deeper extent. So I had to take something called that worm suture. That is just at the external os, that cervical lip. I had to close with mattress at 3 o'clock, 9 o'clock, and 12 o'clock, 6 o'clock. That kind of suture I had to do because I couldn't go to the extent of doing McDonald's near the internal os. So what will be the success rate of this kind of cases?
See, normally we are getting so much referral cases as I have started to doing this from our colleagues. Two things is very much important. Three things exactly. Very good anesthesia and topolysis with atosipar. If you will try this, definitely in 80 to 90% of cases, you will be able to push back the bulging membrane. So position, good anesthesia. We have started with the general anesthesia. Now we turn to the regional anesthesia in some of the cases. But we need patient should be totally relaxed, because once patient will be relaxed, position will be there, strip Trendelenburg, and uterus is relaxed, whatever would be the dilatation, definitely in 80 to 90% of cases, you will be able to push that membrane back. You need, particularly at that time, a relaxed uterus and relaxed patient. Then the membrane will not that much become tense, and the chances of rupture of membrane will be also very little.
Thank you so much.
Thank you.
That was a wonderful presentation and nice descriptive videos. And what is the dose of atosipar to be given, just because we have very less time to react at the time?
Yeah, first directly you will give 3.75 milligram IV. Then in a 3.75, one ampule is coming. That okay.
Okay.
And
Wonderful. We can go ahead with the procedure.
Directly, and then start IV infusion.
Okay, during the procedure also.
Yeah, during procedure, and I will continue that at least to 8 to 12 hours. It is very costly. But I will continue with 8 to 12 hours. Some patients we have to continue till 24 hours, tapering the dose. Then you can switch over to the conventional tocolysis.
Okay. Thank you, and best wishes for your election, sir.
Thank you very much. Thank you very much.
Yeah, can I just add a point?
Yes, Meena ma'am. Yes, Meena ma'am.
Yeah, congratulations, Dr. Sarfraz Ghazi. It was a wonderful presentation with all emergency situations being recorded and have given a good outcome. Excellent. And I just would like to share, we had 3 cases of worm stitch and we had continued the pregnancy. And in one case, the cervical length was 1.5 centimeter. We offered an emergency cerclage, but the patient was not willing. At 24 weeks, we continued with admission in the government hospital. She continued till 27 weeks, 6 days, and then she delivered a 1 kg boy baby. Now the baby is fine on CPAP. And the other one was a doctor whom we had done a emergency cerclage plan. On table, she had a cough and the membranes ruptured. And we were like very scared, basically, because she was a OGCN, but we couldn't do a cerclage. After the rupture, we waited for the baby to expel, and then we brought her back. And later she had a next pregnancy wherein we applied a stitch early, and then she had a pregnancy carried till term. So it was a wonderful discussion, all lively videos. Thank you, and all the best for your elections. Thank you for the wonderful opportunity given today. Thank you so much.
So thank you so much, dear chairpersons and sir. So we'll move on to our next last session for the day. That is, we have a very interesting panel discussion on recurrent pregnancy
Stop
loss.
the slide share, please?
I think the panel slides are being shared. Okay. For the panel discussion, I invite our chairpersons, Dr. Sujata Anbalagan, who is the Secretary of Krishnagiri Obstetric and Gynecological Society, and Dr. Vinita Bhaskaran, who is also a member of the Krishnagiri Obstetric and Gynecological Society. Can you move the slides, please? Yes. Vinita ma'am and Sujata ma'am, can you introduce the moderator and experts?
A warm welcome to all. And this is our dear Dr. Rekha Rajesh, founder of Foxy in remote place. I mean, like in Krishnagiri district. We are very proud of you, Rekha. She has done her diploma in reproductive medicine in Germany, PG diploma in reproductive medicine from Warwick, certified high-risk pregnancy specialist in ACOG, master certificate in reproductive medicine in hometown University of London. She has done her. She's a clinical director and for Vijay Shrishti Fertility Center, Hosur, Krishnagiri. And this is Dr. Sujata Anbalagan. She has done her. It's too small.
Yes, ma'am. Dr. Sujata ma'am is the secretary of Krishnagiri Obstetric and Gynecological Society.
Yeah.
Next.
Yes, ma'am.
And Dr. Vinita Bhaskaran, who's also senior consultant at MD Surya Multispecialty Hospital and Baby Hills Fertility Center in Bangalore. And we have our experts for the panel, Dr. N. Sarvana Kumar, who's a professor and HOD at Annapurna Medical College. Sir is also the current president of OG Society of Salem and the treasurer of TN Fog. Next, we have Dr. Vani Madhavan, who's the secretary. Can I have the slide, please? CV slide. Dr. Vani Madhavan, who's the secretary of E-Road Obstetric and Gynecological Society. Dr. Next slide, please. Next slide, please. We have Dr. Josephine Rossi, who's HOD at Mada Medical College, and she's also the executive council member of OXY. Dr. Padma, who's a very senior and senior consultant HOD at Meenakshi Mission Hospital and Research Center, and ma'am is also a very eminent endoscopic surgeon. And we have our team of esteemed panelists, Dr. Bhuvaneshwari from Theni Obstetric and Gynecological Society, Dr. Priya Karanth from again from Theni Society, Dr. Sita, who's a senior consultant from Namakkal Obstetric and Gynecological Society, Dr. Priyadashni Manoharan from Kanjipuram Obstetric and Gynecological Society, Dr. Dhanlakshmi, who's joint secretary of Namakkal of Nagarkoil Obstetric and Gynecological Society, Dr. Satya Sudagar, who's a consultant at Kaveri Hospital and executive council member of OG Society of Salem, Dr. Sri Lakshmi from Krishnagiri Obstetric and Gynecological Society, Dr. Tangamitra from Nagarkoil Obstetric and Gynecological Society, Dr. Hema Priya from Krishnagiri Obstetric and Gynecological Society, Dr. Purnima from Krishnagiri Obstetric and Gynecological Society, Dr. Taslim Ziaullah, who's again from Krishnagiri Obstetric and Gynecological Society, Dr. Sunanda from Salem OG Society, and Dr. Aarti Dargar from Virudhunagar Society. Over to you, Rekha ma'am.
Thank you, Sarfraz sir. Thank you, Madhumita, and thank you all the extreme special guests, invitees, senior faculties, all for giving us this opportunity. It's indeed a pleasure to present in this esteemed group. And I would like to tell Sarfraz sir has been very persuasive and committed to organizing this program to perfection. And yes, we've been a little lacking because he has given us the whole textbook as a panel. And to put it across in the given time limit, I think is going to be a very, very difficult task. But we have tried to do our best, and I think we should all do it together well. Okay.
We are confident enough, ma'am. You have prepared a great panel.
Sarvana, share open.
Dr. Rekha ma'am has prepared a very great panel for our esteemed panelists.
In this panel, we are two of us moderating. One is myself, Dr. Rekha, and the other is Hemapriya.
Yes, ma'am.
Slide share. Yeah, but yeah. Is it seen?
Yes, now okay.
Yes. Yeah, so we are here together to do this recurrent pregnancy loss, a panel discussion. And this is Dr. Hemapriya and myself together. And the first case I would like to discuss with you people is a 29-year-old female, non-consanguineous marriage, history of two pregnancy losses. Her first pregnancy was a natural conception, but an embryonic pregnancy. And 6 months later, second pregnancy, natural conception, a miscarriage. What is that? What happened?
Your slide is visible. No problem.
Yeah. It's not inge kamikilla kanna. Adu minimize பண்ணிட்டேன். Yeah.
Make it full screen. Yes.
Yeah, I've done it. Yeah. So 6 months later, she's got a second pregnancy with natural conception. Again, miscarriage at 7 weeks and underwent medical termination. And she has now come for a preconceptual counseling. So how do we want to take it forward? What would you do as the diagnosis? Like I have discussed, I'd request the panelists to take it in order as printed in the brochure. Dr. Bhuvaneshwari?
Yes, ma'am.
Yeah.
So according to RCOG, recurrent pregnancy loss is 3 or more consecutive pregnancy losses before the period of viability. But we can start evaluating even after 2 consecutive losses, ma'am. According to ACOG, it's 2 or more consecutive pregnancy losses. So we can start evaluating the patient.
Yes, ma'am. As you rightly said, the current tertiary recommendations, in line with the previous recommendations, diagnosis of RPL can be made from the loss of two or more pregnancies. Even the current RCOG has changed its guidelines from 3 to 2, and we can start evaluating from 2 pregnancy losses.
Yes, ma'am.
And with regards to terminology, primary RPL refers to multiple losses in a woman with no previous pregnancy beyond 24 weeks, and secondary RPL refers to multiple losses who has already had a pregnancy continuing beyond 24 weeks, and tertiary RPL refers to multiple pregnancy losses sandwiched between normal pregnancies.
Yes.
Now, what do you think would be the etiology and the risk factors for RPL? Dr. Priya Karanth?
Yeah, in this case, the patient has had 2 early pregnancy losses. So first things first, I would like to consider mainly endocrine causes of RPL. Basic tests like sugar profile, HbA1c, and thyroid and hyperprolactinemia, I would like to rule out. And yeah, before that, a basic ultrasound pelvis is warranted, definitely. And along with that, because one was an embryonic pregnancy and the other one was a miscarriage, both within 9 weeks of gestation, I would also ask for APLA profile.
So usually the etiology could be, the general.
I answered based on this question. Yes. Otherwise, the other could, because of the second trimester losses and all, the etiology could be different.
Yeah. So here, now the evidence considers both maternal and paternal age in RPL, which it increases with age. The uterine pathologies could be either septate or bicornuate uterus or any other acquired endometrial synechiae polyps or leiomyomas. The genetic issues could be embryonic or chromosomal heteromorphisms and parental karyotyping abnormalities. Infectious agents, pathogenic infections, decreased lactobacilli concentration, endocrine disorders, thrombophilia factors, immune pathology, vitamin D deficiency, other factors like smoking, alcohol consumption, environmental factors, etc., and idiopathic. or unexplained etiology. Dr. Sita, how do we evaluate this couple?
We can go for the investigations, ma'am. As she has already mentioned, we can do the three-dimensional ultrasound, TVS, and measure the thyroid stimulating hormone and thyroid peroxidase antibodies, and the glycemic control the past 3 months with the HbA1c and APLA screening, ma'am.
Yeah. Now, would you want to do a genetic testing for this patient, Dr. Dhanalakshmi?
Ma'am, genetic analysis of pregnancy tissue is usually not recommended, but we can do a parental karyotyping for individual assessment for a diagnostic purpose.
Yes, ma'am. Genetic analysis of pregnancy tissue is not routinely recommended, but it could be done for explanatory purposes. The couple are persistent. They want to know what is the reason. And according to ESHRE, in case we're doing genetic analysis of the pregnancy tissue, array CGH is the recommended testing. And parental karyotyping is also needed to rule out translocations. So in case the products of conception, we can have 3 kinds of reports. So one, if it's aneuploidy, mostly it is sporadic, so no further workup is required. In case it comes as an unbalanced translocation, then parental karyotyping is warranted because there could be balanced translocation in the couple and the recurrence rate is almost 40 to 50%. And if the products of conception report comes as euploid, we can start working up for other causes.
So now what do you think is the role of testing anti-thyroid antibodies for this patient? Dr. Satya?
Yes, ma'am. Actually, we can do a TSH profile and anti-TPO antibodies also, because they also can cause these early trimester losses. So it's better to do an endocrinological workup also.
So the ESHRE guidelines recommend that TSH and TPO antibodies is recommended in women with RPL. Abnormal TSH levels should be followed up with T4 testing in women with RPL.
Yes, ma'am. As you rightly said, thyroid antibodies have shown a strong association with recurrent pregnancy loss. There are several systematic reviews and meta-analysis to support that. So what is the association between thyroid profile and recurrent pregnancy loss? So this is an overview given by ESHRE. So with respect to hypothyroidism, yes, it has a strong association. With respect to subclinical hypothyroidism, yes, it is associated with RPL.
Yeah.
With regard to hyperthyroidism, we still don't have a clear causal association. And anti-TPO antibodies, yes, it is associated. With regards to anti-thyroglobulin antibodies, there is no clear association documented as of now.
So is there a role for anti-nuclear antibody testing in RPL for this patient? Dr. Sri Lakshmi?
Yes, ma'am. Yes, ma'am. Anti-nuclear antibodies can be tested, but it's not strongly recommended, only conditional.
Yeah, that is the ESHRE recommendation given. Anti-nuclear antibodies have been significantly associated with recurrent pregnancy loss. Even in the absence of any defined autoimmune disorder, isolated anti-nuclear antibody positivity has been significantly associated with RPL. And as you said, it's a conditional recommendation from ESHRE. It could be considered for explanatory purposes.
So would you offer sperm DNA fragmentation testing for the male partner?
Maybe done, ma'am.
Dr. Thangamitra.
It can be done.
Good evening, ma'am. We can do sperm the fragmented DNA fragmentation, ma'am. In 2 or more losses, I think for defining the cause, we can better do that, ma'am.
Yeah. So sperm DNA fragmentation in recurrent pregnancy loss. There is a male partners with a history of RPL have a significant higher rate of sperm DNA fragmentation compared to partners of fertile control women. This has been shown in many studies. And assessing this in couples with RPL could be considered for diagnostic purposes. So what is the role of testing prolactin, Dr. Purnima?
until unless there is some symptoms associated with the pregnancy loss related to hyperprolactinemia, serum prolactin need not be tested, ma'am.
Yeah. So
yes, ma'am. As you said, prolactin testing is not recommended as a routine in the absence of any clinical symptoms. But according to the ASRM committee opinion, but that is was in 2012, they recommend screening for thyroid or prolactin abnormalities, irrespective of the clinical symptoms.
So according to the ESHRE, to summarize the investigations in recurrent pregnancy loss, these patients, what is routinely recommended when you're seeing 2 or 3 losses would be lupus anticoagulant, anticardiolipin antibodies, or beta-2 glycoprotein, the TSH and anti-TPO profile, and a compulsory 3D ultrasound. Otherwise, SSG probably if required, if you want to rule out the uterine anomalies. For explanatory purpose, ANA and sperm DNA fragmentation and a CGHRI for pregnancy tissues. And in selective cases, parental karyotyping and HLA class 2 secondary to RPL after the birth of a boy. What is not actually recommended or compulsory is other immunological testing or metabolic or endocrine markers. I request the experts and chairpersons, if they have any opinion in this case or would want to suggest anything, to give their view.
Madam, in spite of all this testing and everything, most of the cases we don't get any cause. And sometimes even after recurrent pregnancy loss, they have normal pregnancy and a normal delivery.
Correct.
Afterwards.
Yes.
Yes, ma'am.
The most importantly, for these patients, we have to take a proper history. Otherwise, if you don't take a proper history, then probably you'll be going on doing so many investigations which are not required for them. And many instances, these investigations, we are not going to do anything for them more, like even karyotyping, DNA fragmentation. It is only for those explanatory purpose of those patients who come and ask us that what else can be done, why it has not been, I am not able to become pregnant. And that in those conditions, we may be able to do the other special investigations. Otherwise, routine investigations and reassurance, tender loving care is going to help our patients. And majority of them, they get pregnant unless until it is a balanced translocation or something like that with chromosomal problems, which happens to cause the problem in the early trimester. Otherwise, majority will become pregnant afterwards.
Yes, as you said, 50% of the cases of RPL are idiopathic or unexplained. And generally, even after 3 pregnancy losses, we have around a live birth rate of 60%, 60 to 65%, sir, as per evidence.
We'll go to the next case. This is a 23-year-old lady with history of 2 pregnancy loss, missed miscarriages at 11 weeks and 9 weeks of gestation. RPL workup done outside, TSH, HbA1c, APLA, APLA normal, ultrasound 2D report shows partial septum of uterus with 1.5 centimeter length. Dr. Tasli?
Yes, ma'am. Good evening. So this patient, she is actually a case of primary RPL. As you said, these are 2 consecutive losses at 9 and 11 weeks. And all the investigations done clearly states that there is a uterine septum. So I'd like to confirm the uterine septum. Since it's a 2D ultrasound, I'd like to confirm it with the 3D ultrasound. And if I'm
So the 3D ultrasound shows this picture, ma'am. It's a partial septum.
Yeah.
So would you like to do an MRI, ma'am, to confirm the diagnosis, or you think
MRI is it's routinely not, MRI is routinely not recommended, ma'am. A very good 3D ultrasound actually can pick up the septum very well. So I would not recommend routinely MRI. Of course, if there is any other associated anomalies, then probably, but routinely it's not recommended.
Yes, ma'am. ESHRE goes saying that MRI is not recommended for the diagnosis if a 3D ultrasound is really good and if you're very sure about your 3D ultrasound. And also nowadays we see a lot of adenomyosis, so it is not just for ultrasound is not just for uterine anomalies, it's also to find out if there is any adenomyosis. So would you want to do a septal resection for this patient?
Dr. Sunanda?
Yes, ma'am. Keeping in mind that other panel for RPL are negative, then most probably she would have aborted because of the septum. So I would like to do a septal resection for this patient, ma'am.
Anybody has any other opinion?
Hope for argument, actually.
Actually, madam, because of a 1.5 centimeter septum, the RPL probably could have been another reason, or it would have been implanted on the septum. We take a chance for that the pregnancy might implant on the other sides where it can be, but it can have a better outcome. The problem with the septal resection is if we do it excessively, then probably it can go for adhesions. And if the septum is, if we are able to resect the septum with just the scissors, that is enough. But if we are using a cotton, if we are using a energy source, then probably it is going to go for more of adhesions. So it is better.
Sarnan sir, you have Gnanashankar sir there in Salem with you.
Okay.
Okay. Next. So as per evidence, we don't have much evidence for septal resection in RPL. This is one retrospective monocentric study. It's a very small study though, and they found some increase in live birth rates and decrease in recurrent miscarriages when there was a septum incised. But according to the Eshery guidelines, they say that one small RCT, which was a trust trial, did not show any benefit of hysteroscopic septal resection. But we know that trust trial was not meant for recurrent pregnancy loss, and it was only for preterm birth infertility or one pregnancy loss. It was not for RPL. But ASRM recommends to offer hysteroscopic septal resection to patients with the septum and history of recurrent miscarriage.
Any other views on the septal resection or treatment of uterine anomalies?
Not all septums need to be resected. Like as sir had told, maybe sometimes when the implantation happens in another place, you can just give a chance.
Yeah. Yeah. In my experience, though, I've seen quite a few pregnancies who have conceived with septum, and then only probably at section we've identified there is a septum. And yeah, it has been an experience. But yes, sometimes they get away and sometimes they come and get caught with us. So I'd like to go to the next case.
Before that, wait,
Huh?
Rekha ma'am.
Yes, sir.
I just want to know if our experts are there, if they want to give any expert comments
So
on.
that's what I asked the experts, sir.
Okay.
Sir, I have given my opinion.
Yes.
Yeah.
Yeah.
Thank you,
So now this is our next case where we have a 34-year-old woman with regular cycles, 3 first trimester pregnancy losses. First pregnancy 2 years ago, complete miscarriage at 9 weeks. Second pregnancy 1 year ago, miscarriage at 8 weeks. And third pregnancy 5 months ago, missed miscarriage at 10 weeks. So with her family history, her mother died due to pulmonary embolism after her last child. Her brother has had DVT at the age of 29. Her sister has had 2 children born preterm with severe preeclampsia. What is the likely underlying diagnosis for RPL? Dr. Bhuneshwari, would you want to take this?
It's Apla syndrome because of the clinical evidence.
Yeah.
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 Apla, it consists of.
Yeah.
Yes,
Yeah, tell me, doctor, please go ahead.
It consists of clinical and laboratory criteria. At least one clinical and one laboratory criteria should be met to make the diagnosis of APLA. And the clinical criteria includes 3 or more unexplained consecutive spontaneous miscarriages before the 10 weeks of gestation with maternal anatomical or hormonal abnormalities, paternal and maternal chromosomal causes excluded. 1 or more unexplained deaths of a morphologically normal fetus at or beyond 10 weeks of gestation, and 1 or more preterm births of a morphologically normal neonate before the period of 34 weeks of gestation due to eclampsia, severe preeclampsia, or any form of placental insufficiency. And laboratory criteria tested positive for lupus anticoagulant or anti-cardiolipin antibodies or beta-2 glycoprotein. That should be done twice, at least 12 weeks apart.
Yeah, so we should have one of each, or at least one on one side and 2 of the other. Yeah.
Yes.
So how do you manage this patient, Dr. Priya?
Yeah, I would, this subsequent pregnancy, I would counsel her regarding the presence of, once the APLA is confirmed. And she also has history of thromboembolic events in her family members also. So I would like to start her on low dose aspirin, 150 milligram at night dose, and also give low molecular heparin of 0.4 ml, 40 milligram prophylactic dose from the onset, at the positive beta HCG, and continue till 36 weeks.
Yeah. As
per the green top.
We should also be vigilant for preeclampsia in this patient.
Yes. Proper counseling is very important.
Yes.
About the disease and the effects of the disease at each stage, at each trimester, how the disease can affect the fetus or the embryo. So vigilant for FGR, vigilant for preeclampsia, and vigilant for preterm delivery because of the APLA per se.
Correct. Yeah. So the Green Top guidelines also just gives us the same thing. They give aspirin 75 mg orally even before pregnancy, unless there are no other issues, and heparin 40 mg subcutaneously from the time the pregnancy test positive till at least 34 or 30, up to 36 weeks is what we can consider. Do the experts have any comments on this, or do you any other communication?
Yes. Many times what happens is we think that it is APLA, and all the history suggests that it may be APLA, but the investigations, they consistently show that it is negative. IgA, IgM and IgG consistently become negative, and now we are in a fix whether to start them on heparin and aspirin or not. But temporarily we do start. Otherwise, if I don't start, somebody else will start. So and we find that starting heparin and aspirin are definitely going to help the patients, even though they are APLA negative.
See,
with all those criteria of the history that we take.
Yes. Dr. Sujata, Dr. Vinuta, do you have anything to say?
Just like we start progesterone before, for every pregnancy recently, we don't want to be in trap, So I think for one pregnancy loss, we have to start with heparin or aspirin.
Yeah.
Because all pregnancies are not beds of roses. So we should always tell the patient about this, and we should also be a little vigilant on this. So that because we know how the patient changed the doctors for one pregnancy loss. So let's be on that.
Dr. Vani, Dr. Josephine, Dr. Padma, do you have any takes? Yeah. So we go to the next case. This is a 28-year-old woman married for 7 years, para 0, live 0, abortion 6. She has repeated miscarriages at 12 weeks, 10 weeks, 14 weeks, and again 10 and 12 and 11. Her RPL workup shows 3D ultrasound, which is normal, TSH normal, anti-TPO normal, HbA1c normal, APLA, like Saravanan sir just told us, it's all normal. Sperm DFI is again normal. So with all this report, she has come and everything is normal. And now where do we start and what do we do? Dr. Priya, would you like to take it?
Yes, ma'am.
Yeah, somebody else is saying.
Okay. I'm Dr. Priyadarshini here. Ma'am, since all these RPL workup has come to be normal, I would like to see any infection is there for the patient. We would, because it looks like unexplained RPL. So we can do torch screening is missing here. So we have done an APLA profile and all that. So yeah, we can evaluate her if she's having any infection. Torch screening can be done. And if any vaginal infection, if she's having, also can be evaluated. Any chronic infection, sometimes patient misses to say that they have all these infections and they don't get treated. Maybe that is one of the cause, because she's having every abortion at 12 weeks, 10 weeks, exactly at around 10 to 12 weeks. So I think we should evaluate her torch screening and any vaginal infection.
So,
and we can also look for tuberculosis for this patient, some chronic endometriosis like TB.
Yeah. But nowadays, I think we're not doing TB. TB access.
In endometrial biopsy is not done.
Yeah. See, infection testing, torch screening, bacterial vaginosis, or chronic endometriosis is the next way of going forward. But recommendations show
torch screening is not recommended by any of the guidelines. Bacterial vaginosis, no clear association in recurrent pregnancy loss, though it has been associated with preterm labor and PPROM. There is no clear association in recurrent pregnancy loss. So what about testing for chronic endometritis?
Dr. Sita?
Ma'am, current evidence doesn't support screening for chronic endometritis now. We need more studies to show losses due to chronic endometritis. We need more studies.
Do they do in practice?
Do we do it in practice? Anybody doing treatment?
With miscarriages, would you like to offer the patient or would you like to screen for chronic endometritis, ma'am? Because we don't have any other cause.
Dr. Priyadarshini?
Ma'am, endometriosis, since our ultrasound also shows normal, or 3D ultrasound, okay, for the anomalies. Endometriosis is causing infertility is not very common, ma'am.
No, we're talking about endometritis, doctor.
Infertility, but not RPL.
No, we're talking about endometritis.
Endometritis, yes, ma'am. In vaginal swab we do take, no, and all that infection rate. But I don't think.
Dr. Satya?
Ma'am, if she has a chronic endometritis, there'll be problem with the implantation, no, ma'am?
Yes, most likely. In hysteroscopy, mostly we find those strawberry spots and there is changes. In that case, probably we'll be testing for chronic endometritis, ma'am. Otherwise, routinely we don't do testing for chronic endometritis. We tend to look for the plasma cells for the CD138. That is mainly in case of recurrent implantation failure rather than for recurrent pregnancy loss.
Correct. Yeah.
Can we also do endometrium microbiome?
Yeah, we will be
for
coming
this
to
patient,
that.
ma'am?
Yeah, we'll come to that later.
Yeah, can be done, but we'll be coming to that.
Okay, thank you.
I think evidence for chronic endometritis and endometrial microbiome testing are almost similar with regards to evidence. And anyway, you're going to take an endometrium sample. So rather do both.
Yeah.
Do a histopathology and check for endometritis also. So yes, we do have emerging evidence for recurrent pregnancy loss too. We know that it can cause RIF, but we do have evidence for recurrent pregnancy loss too. We do have studies for that. But the problem is many studies have used different criteria to diagnose endometritis. So some have used 1 or 5 plasma cell, but then again, it's a histopathological diagnosis along with immunohistochemical staining.
Yeah, and I think most of us in the OPD sometimes give empirical antibiotics, cyclin, clindamycin, or even antifungals, and some of these people do come with white discharge. So usually most of them are either pre-treated or over-treated. So when they come, I think sometimes we also miss out on the subclinical infections. So what do you think is the most important in managing patients like this? Where is the most important role, Dr.
Counseling part.
Yeah, go ahead. Dr. Sri Lakshmi? Anybody can take it.
I think most important is tender loving care for this patient. There's a great association between the limbic system and the immune system. And I think we have to sit down with this patient, talk to her, tell her that even after so many unexplained pregnancy losses, she can definitely have a normal pregnancy. And there is a live birth rate of around 60% even after all this. And then an explanation has to be given for any medicine that we give. And very good psychological support has to be given to the patient. And I think that is the most important thing. And any decision that we make, we should share with the patient. I'm going to do this for you like that. So if she has confidence in the treating physician, I think it helps a lot.
Yeah. In this patient, we think a multidisciplinary team also would help, where you have a physician, a psychological counseling, probably somebody who would help her with the nutrition and exercise, maybe a yoga therapist who will bring down her stress and help her conceive much more in a calm environment, and also discuss the treatment plan with her in such a manner
that we build confidence both, not only with the patient, because she'll be very upset and depressed, her husband and the extended family involvement in decision making is very important, is what I would want to add. Any other doctors would like to add anything else?
Lifestyle modification is another important thing, madam. A proper diet goes a long way. Proper nutritious diet.
Correct.
Avoidance of junk food. And she can reduce her obesity, make her BMI normal before the next pregnancy.
The extended family definitely have a role. The problem with them is their in-laws. If they start using words which will keep her stress levels always high, then probably she will not have the proper environment to conceive.
Yeah,
So
with so many pregnancy losses, one is either her mother-in-law is ready to send her home, or the husband is ready to find another wife. We never know. So
their stress level does not come down at all
because there is something called DNA fragmentation.
yeah, that's exactly why we should explain to them that DNA is also part of this. And I think today, male factor post-COVID, we are seeing quite a few.
Yeah, quite a lot. Percentages
They should also be involved in the evaluation and testing, and ask them to give some blood samples so they understand how it is to get poked, and wait for the reports and things like that. Yes, environmental factors are associated.
Social media, ma'am. Social media.
Yes.
New influencers, their videos.
Correct.
Toxic videos, ma'am.
Yes. Do you think, we're talking about lifestyle and behavioral modifications. We understand that it helps a lot and it's very important. And a lot of evidences also which say that lifestyle and behavioral changes will help. So these women should be advised to maintain a proper BMI. This is according to the Green Top guidelines and the ESHRE guidelines. To stop smoking if they are smoking, limit alcohol both for men and women, limit caffeine for the women, and definitely antioxidants play a good role for both men and women. But there's no evidence or guidelines or studies which actually is going to establish a definitive answer saying, yes, these are the supports we have to give. So actually, Charmila ma'am covered the role of progesterone very well in this, but still we'll continue. And this, Dr. Who's taking the next question? Dr. Sri Lakshmi or Dr. Tangam? Role of progesterone?
Yes, ma'am. I think we can give progesterone there, as ma'am has said. It is more better to give with vaginal bleeding. Though we can also give when there is 2 or more losses. I think we can give progesterone because in many trials the live birth rate is more with progesterone patients than in placebo patients, ma'am. So I think we can go with progesterone.
Yes, ma'am. There are some trials, but this is one of the largest trial by Ari Kumarasamy, but this did not find any difference in the live birth, but this was not for recurrent pregnancy loss, but this was the promised trial, but this was just with one miscarriage and recurrent miscarriages too, but without any vaginal bleeding, but they didn't find any increase in live births. This is the study which is the most important, because this was the quoted one by ESHRE, and the ESHRE changed its recommendations based on this study. Basically, this was done in women with early pregnancy bleeding, and they found that there was an increase in the live birth rate, especially in those with 3 or more previous miscarriages. So in unexplained RPL, progesterone, ESHRE says that vaginal progesterone may improve live birth. This was based on the PRISM trial in women with 3 or more pregnancy losses and vaginal bleeding in a subsequent pregnancy. I think all of us give progesterone when there is recurrent miscarriage. So which progesterone would you like to choose, ma'am? This was also covered by Sharmila, ma'am.
Yeah.
Micronized or dydrogesterone, or what is your personal experience? Can we ask the experts, ma'am?
Yeah, experts. Would Vani madam, Sujata madam, Vinuta, Dr. Sarvanan?
What is your personal preference?
I would prefer micronized progesterone, preferably.
Micronized progesterone, madam.
Because it's natural and it has.
The problem is sometimes we get patients who have both all type of progesterones.
Mm.
If you see their prescriptions, they will have one dydrogesterone, one micronized one injection, and every sort of, and she will be constipated to the core. So I prefer to give a micronized.
Yes, sir. Yes, sir. Yeah, there's a lot of dilemmas, and and with the number of companies that have come with dydrogesterone and pressurizing everybody in the OPD, definitely we keep swaying this side and that side. But there is evidence which says that micronized progesterone, especially given vaginally, has better outcomes. And we've seen there's been a lot of other doctors who've been even in case of bleeding, they have given vaginal progesterone, and the outcomes have been good.
And we'll have to accept that most of the studies in with dydrogesterone are funded by the pharma.
Yeah.
Yeah. Yeah. And what is the role of vitamin D? Who will take it? Dr. Sunanda?
Yes, ma'am. Vitamin D deficiency can also cause recurrent pregnancy loss because vitamin D has some immunomodulatory effect, ma'am. So the patients who are deficient of vitamin D, studies show that patients with vitamin D deficiency, they have recurrent pregnancy loss, and the patient who have normal vitamin D. So supplementation with vitamin D prophylactically can prevent recurrent pregnancy loss in these patients.
There is yes, as you said, ma'am, there is a biological plausibility for vitamin D and pregnancy loss, vitamin D deficiency and pregnancy loss, because vitamin D is thought to have an immunomodulatory effect, and it decreases the Th1 cells, decreases interleukins, and it upregulates the Th2 cells. We do have studies and a meta-analysis which has shown that there is an increased chance of miscarriage in vitamin D deficient women compared to vitamin D deplete women. But we still don't have any study which has shown that preconceptional vitamin D supplementation would reduce recurrent pregnancy loss. So Eshery's stance is that preconceptional counseling could, in women, could include prophylactic vitamin D supplementation. So with such pregnancy losses, would you use hydroxychloroquine, ma'am?
HCQS, Dr. Purnima?
Even though there are no clear guidelines for use of HCQS, ma'am, but it will help in the form of immunomodulation in recurrent pregnancy loss, ma'am. We can definitely use HCQS.
So when do you start, ma'am, and what is the dose that you usually give?
Ma'am, we can start from first trimester only, ma'am. 200 mg BD we can start, ma'am.
Any of the experts, Dr. Sarvanan, Dr. Vani, Madam, Sujata?
Madam, I have no experience in using hydrochloroquine. I don't give.
We haven't used HCQ.
Maybe probably I will try in the next case if nothing works out. But till now I have not used hydroxychloroquine.
Yeah. Generally, they say that it takes 6 to 8 weeks for HCQ action to begin. So better, it's advised to start even before pregnancy, before attempting conception for at least 2 to 3 months. Though
Like
we don't have strong
ecosprin-
evidence for this, there are very, very few studies in recurrent pregnancy loss and hardly any. This was one study which was which was a registry-based study. This did not have any control group, and they just found if patient is already put on hydroxychloroquine, is there any difference in the miscarriage rate? And they found no difference. It did not reduce even further miscarriages. So, but we need more evidence. We have another study waiting. Maybe with the results of this study, this multi-center randomized trial, we'll be having more better picture.
This will give us a better evidence whether we should start. Yes, there are some workups being happening and in infertility patients where we have recurrent implantation failures, and even if they are being treated by the rheumatologist, HCQS has been showing better implantation rates in these women. Next.
In case of ANA positive and TPO antibody positive patient, like we are giving ecosprin 3 months preconception, can we give HCQ also? No?
Already
3 months.
Then
We don't have any guidelines.
there is
ma'am,
no
but most of us-
recommendation, but yes, unofficially, yes, we are giving.
Off-label use.
Off-label, but on record.
Okay, ma'am.
Physicians
Thank you.
start them on HCQs prior to our prescription, ma'am.
Yeah,
So
when we
continue.
have a patient like this with 5-6 pregnancy losses and
We
don't
have
know
to
which
try it.
direction to go, so we want to now give her everything possible and see that she carries this pregnancy. to at least viable term. Yeah.
Well, long-term HCQ is
Okay.
also not recommended, ma'am. She needs to a cardiologist review ECG and all if she's been taking for more than 6 months. Some patients we do see taking HCQ for almost a year, which is not recommended.
Okay. So role of steroids in RPL, Dr. Taslim?
Off-label, as you said, ma'am. Definitely, it's not recommended, but it does significantly increase the ongoing pregnancy rate. Actually, it has, in many of the studies, it has been shown, but it is not yet recommended, ma'am. Actually.
Yeah, as you said, most of the studies have shown some benefit in terms of ongoing pregnancy rate, but still ESHRE does not recommend it because of safety concerns and long-term. We don't have data for long-term outcomes, and many patients have developed, especially elderly women have developed GDM and hypertension also. And basically, in view of safety concerns, ESHRE doesn't recommend glucocorticoids. That was the justification given. We have another trial awaited. This is exactly what we want. In unexplained recurrent pregnancy loss, this is an ongoing trial, double-blinded, placebo-controlled, multi-center randomized trial. We are waiting for the results.
Now, Dr.
Ma'am, we have some ambiguous zones and uncertain domains in RPL, as all of us know. So we thought we'll take a quick poll just to know whether all of us know what the evidence says. But we just want to know if, like, what you would do, what is your personal opinion regarding this?
Testing.
So testing for thrombophilia, can we have the experts to guide us and give us their opinion? We all know the evidence, but what is your personal take on this? What is your stance? What is your experience?
We find these as the gray zones. Sir, Saravanan sir.
Yes, madam.
So you can also say something, no?
Yes,
where are you?
Me working in the medical college, unless until it comes in the textbooks that it is definitely helpful, I'm not going to do all these investigations.
Yes, yes. Sarfraz sir, are you there? Madhumita?
Yes, I'm there.
Sir, what is your take on these investigations? Sir, testing for thrombophilia?
Same as Saravanan sir.
Okay, sir.
Until and unless it is not guided or recommended, there is we are not going to do these all things. Only I want to share one case of HCQ. Patient was having ANA positive, and patient has been started by the she was having recurrent 5 pregnancy loss. She recently diagnosed by the rheumatologist, and she was on HCQ when she got pregnant, and that pregnancy was survived. So it is you can say it is like not correlated, but this was the one case which I encountered.
Yes, sir. Even we have seen these patients with though the titers are not very high, ANA positive, and with HCQS, conception has happened, sir. So according to the evidence, testing for thrombophilia.
Yeah, ESHRE says it can be done if additional risk factors. Does anybody do NK cell testing in your center?
No. Yeah, it is involving actually NK cells, and especially from the endometrium, and we are doing it for recurrent implantation failure, but not for recurrent pregnancy loss. So again, when we are doing that endometritis investigations, that's when NK cell comes forward. So otherwise for RPL, there is no evidence.
We still don't have a proper cutoff, and some studies have showed increased uterine NK cells with RPL, and some have shown decreased uterine NK cells. With RPL, we still don't know exactly which way to go.
What about homocysteine levels, sir? Anybody can take these questions. Homocysteine levels?
No, ma'am.
Not routinely.
No, not routinely done.
In the absence of symptoms, ESHRE doesn't recommend. HLA testing?
Not recommended in routine practice. Yeah. So what is your take on intralipid? Anybody's using intralipid for RPL? No? So what does even the evidence says no?
In terms of safety concerns and efficacy, ESHRE doesn't recommend.
IV immunoglobulins?
Not routinely recommended.
Not routinely recommended. Yeah.
Yesterday's recommendation is conditional, but this was based on one small RCT published in 2022, which showed increased live birth rates with 4 or more pregnancy losses, like unexplained pregnancy losses, but still we don't have good quality evidence to support this. Does anybody use lymphocyte immunization therapy, LIT?
I have experience in using LIT, but more in RIF, not in RPL. Yeah. Endometrial scratching?
It's more done in RIF than RPL, ma'am.
Yeah, yeah.
But some people.
But even that has no evidence. Yeah, and it's
no
not
evidence.
recommended. Yeah. There is one
HSA
group which
doesn't
came
recommend
forward
anything.
saying endometrial scratching gives us better result. There's another group which says endometrial scratching does not help. So again, we're always going forward and backward. And I think it's not recommended. So when the guidelines say no, we'll not do it. GCSF, granulocyte stimulating factor.
Not recommended.
Low dose aspirin or
All
heparin.
these are not recommended, ma'am.
Not
But
recommended,
sometimes,
but everyone uses.
yeah, that's why we wanted to know because
Yeah. What we want to bring
because
into the
evidence
forum
says
is, yes, there are many things which are not there by the studies or the guidelines, but there is evidence that doctors have been prescribing it. We've seen prescriptions.
we just want good practice points from
Yeah.
the
So if
experts
they
and
have an
families.
experience or about using this and having good results, I think at the end the patient and the live birth rate or the pregnancy going forward is what matters. So probably we should also together put up a study or work together in publishing our own data. So what's your take on low dose aspirin or heparin preconceptionally
In unexplained pregnancy.
in unexplained pregnancies?
More than 2 losses. I mean, 1 loss itself for low dose aspirin. And heparin for more than, even for APLA negative also we can start on heparin.
Yeah.
APLA positive patients, we start preconceptionally, ma'am. And APLA negative, we start immediately after conception aspirin. And maybe depending upon the patient's affordability, we start heparin immediately or after the FH.
There is more evidence when you start after the pregnancy is positive.
Okay.
Yeah, yeah. So endometrial microbiome testing. Dr.
It is
Aarti
also not.
Dr. Aarti? She's not there. Okay.
It's also not routinely recommended, but it is coming up in recent days that treating an endometrial dysbiosis is a major cause of RIF and RPL. So doing the endometrial microbiome testing, we can treat the dysbiosis and can improve the pregnancy rate.
Yeah.
We do have evidence to say that endometrial dysbiosis, vaginal dysbiosis, or alteration in the gut microbiota is associated with pregnancy loss, although the evidence is emerging. But the problem is different studies have shown different bacterial profile in RPL. But putting together all these studies, what we understood is lactobacillus depletion is associated with RPL, and not just depletion, even altered lactobacillus flora, like increased inner species and reduced acidophilus or rhamnosus species is associated with RPL. And also increased diversity of microbiota, like in spite of just 1 or 2 organisms, if there is a plethora of organisms, that has also been associated with RPL. And increased levels of Gardnerella, Proteobacteria, Ureaplasma, Staphylococcus, Streptococcus. They've identified many bacteria. We've just put organisms common to all the studies. Klebsiella have been associated with RPL.
Purnima? Probiotics for recurrent pregnancy loss?
Do you use probiotics, ma'am?
Ma'am,
In
routine, we
unexplained
are
recurrent
using
pregnancy loss.
unexplained pregnancy loss. It can be given, ma'am. Because bacterial vaginosis is one of the reason, might be one of the reason for recurrent pregnancy loss. So probiotics will definitely help, ma'am.
Have you missed any of the doctors? If so, please take the next question.
Yeah, we do have very few studies, preliminary studies to say that probiotics is useful in recurrent pregnancy loss. So we'd like to conclude with some
Probiotics not.
Yeah,
not to
Doctor.
be given but pre-probiotics not to be given during first trimester, right, madam?
It was before pregnancy, ma'am.
Before pregnancy, and then
when she comes for pre-pregnancy counseling.
Yeah. Do the senior panelists and doctors have anything to say?
Probiotics in between pregnancies, and instead of doing this microbiome, give them a course of doxycycline and metronidazole. Probably that will help them. And the probiotics is not much harmful in outside this pregnancy, and sometimes even in pregnancy they give probiotics. So empirically we can give it just like a placebo, where we don't give, instead of not giving anything, give them these probiotics as a placebo rather than doing any other testing. So that can be given for them.
Thank you, sir. So we have some few take-home points. So RPL is multifactorial. As sir said that the detailed family history, medical history of the patient sometimes would give us a diagnosis. So systematic evaluation is essential. Not all patients need extensive testing. And optimization of lifestyle, behavioral modifications, thyroid levels and sugars is mandatory. And it's better to avoid over-treatment. And in unexplained RPL, prognosis can be favorable with just supportive care alone. Emotional support and reassurance are central to effective management. Can we have some take-home points from the experts, please?
As I said, there should be a good history at early itself, because I had one patient. She had RPL. I mean, first she got married, and after 8 weeks she had one abortion. In between, after the next month, again she conceived. Again at 7 weeks she had abortion. But there's taking a proper history. She was on antifungal.
அவங்களுக்கு ஃபோன் பண்ணுங்க, என்னால பண்ண முடியாது, பண்ணுங்க.
Go on, Dr. Vinutha.
The patient was an antifungal treatment from almost 6 months, it seems, which she didn't tell us. So that iatrogenic cause also should be ruled out, I feel, when you take a proper history. Then later on, she stopped her antifungal, and then the subsequent pregnancies were normal, and she had a good, healthy pregnancy.
Yes, that's exactly where we come back to again, that basics is very important with history taking, spending time with the patient, understanding. Sometimes they will not give us their old prescriptions files, and to actually collect history, and they would want to, they'll actually come and challenge us to understand, see, I've had all these things, but I'll not give you any evidence, but you still diagnose what is going on with me. So I think that does not help at all. And what's not.
Hi, ma'am. Can I share a point?
Yes, please.
Yeah. Okay, I'm Dr. Josephine, ma'am. Recently, I had a patient. She came from Kolkata with 3 abortions, and she was evaluated completely. And she was diagnosed to have, she had an endometrial biopsy which showed TB endometrium, and she was started on prophylactic ATT drugs, but that patient was not on a regular follow-up. What she did was, she just took the medicines for 1 week. Since she was not counseled properly, she just withdrew the medications on her own. After 1 week, she did not go to any referral center. Then she came back to me again for a diagnostic hysteroscopy and for an endometrial biopsy. So such patients, if you see, as the moderators did a very good job on the very good case scenarios, and they discussed all the reasons. But any patient in our setup, in an Indian setup, complaining of recurrent pregnancy loss, you can also think about endometritis, the most commonest being the tuberculous endometritis. That is the take-home thing that I wanted to say from this patient, which I have seen. So TB endometritis, always keep it in mind when you have a patient of endometritis. And then we had to counsel the patient for taking extra treated with ATT for the next 6 months. And I had advised her to wait for 6 months till the course is complete and then plan for a pregnancy later.
Yeah.
Thank you so much, ma'am.
Yes. So
recurrent pregnancy loss. The success lies not in doing
It
more.
was very wonderful, Rekha, and for selecting such lovely subject. Amazing it was, and a lot of information and interaction. And I think in a short period of time, I think you have done it very magnificently. Really, hats off to you and great applause for you both. Hema Priya, behind, I couldn't see you at all, but I'm searching for you.
Yeah, just sitting
So,
beside.
Yeah.
it's very sweet of you for very great interaction. I think we all enjoyed a lot. I've been there from beginning till end,
Yeah.
non-stop. It was going so meticulously.
So what we want to conclude finally would be is in RPL, the success lies in not doing everything or doing more, but in doing what is evidence-based, individualized, and being compassionate with the patient. Yeah. Thank you for I'd like to thank all the panelists who participated, and I'm sure we've not left out anybody.
Thank you very much. Thank you very much,
Thank you.
Rekha ma'am.
Yeah.
And Hema Priya, you have prepared a vibrant panel on evidence-based things. You have covered each and every aspect. Though RPL is a very huge topic, and to cover it in a hour and to prepare a panel in a 2 or 3 days, it is not possible. But you did a great job. Thank you very much. Now I understood why you took that much of time, because you want to give your 100% for this panel, and we have seen that. You did a great job. Thank you very much.
Thank you. Thank you, Radha Madhavi Madam. Hi.
Bye-bye. Thank you.
Hi, Radha.
Kazi sir, congratulations, and we wish you all the best for your.
Thank you very much. I need all your blessings, and I will definitely meet who are coming for the Kodaikanal conference. We will definitely meet in person.
Thank you. Bye-bye.
Thank you, Madhumita. Thank you.
Bye bye.
Thank you. Rekha,
All the
wonderful
best for your elections.
Madhumita, you can give concluding remark. Hello. So if Madhumita is not there, I am very much thankful to all the chairpersons, all the moderators, experts, panelists, all the speakers, especially Sharmila ma'am, all our guests of honors and all our guests, Dr. Sampath Kumari ma'am, Dr. Jayam Kannan ma'am, Dr. Ramani Devi ma'am, Dr. Palaniappan sir, Dr. Vidya Prabhakar ma'am, and Dr. Amala Devi. I'm thankful to each and everyone who supported me and who involved in this webinar, starting from Dr. Deepika, Dr. Madhumita, and Dr. Radhika, and also the core Corona team. From there also it was a 2 or 3 sleepless nights to prepare all these things in a hurry. Thank you very much, Bhavna and Mehul from the Corona team. Thanks a lot. Thank you very much for everything.
Thank you,
and for
Vinatha ma'am.
everything.
Thank you, Saranand sir.
Thank you.
Thank you, Kazi sir, and thank you everybody for a wonderful webinar. Thank you. Congratulations.
Radhika,
Yes, sir.
yeah, give your concluding remark.
Yes. I'd like to thank everybody for joining in for this webinar. Thank you very much. A big thank you to all the societies for coming ahead, joining and doing this collaborative effort, and our best wishes with Kazi sir and Sampath Kumari ma'am. And we hope to do many more programs when sir comes into power. So we'll be connected with you, all of us. Thank you to each and every one of you. Thank you so much.
Thank you. Bye bye. Have a nice day.
Thank you.
Have a nice evidence-based practice.
Thank you, sir. Thank you.
Thank you.
Congratulations. Thank you.